The endocrine system, as I'm saying, consists of glands, okay? And then these glands produces hormones for certain functions in the body. Okay, so we have several glands. And then these glands, each of them have a hormone that they produce for its purposes in the body. And then some of the purposes are the growth and development, as someone said. They also help in reproduction. Okay, they help in a lot of functions in the body: growth and development, reproduction, regulation of fluid, regulation of blood pressure and pulse rate. These glands produce hormones to help with these functions. Okay, so we are going to take the glands and then the diseases that usually affect it, and we focus on the NCLEX interest, and then we move ahead. Okay, very good. So as you can all see, the endocrine system is a network of glands that produces and releases hormones. Hormones are chemicals. Okay, hormones are chemicals that are being released into the bloodstream by these glands. So when these chemicals are being released into the bloodstream, it helps with communications, okay, in the body. There are glands. The glands produces hormones. These hormones are released into the bloodstream to help with what? With communications in the body. So these hormones help control many important functions, including the ability to change calories into energies that power cells and organs. Okay, and then the endocrine system affects your heartbeat, as I was saying, how your bones and tissues grow, and even your ability to make a baby. Okay, so basically, the endocrine system produces glands, and the glands also helps with hormones that helps regulate important functions in the body. So I have listed some of the glands. Okay, these ones are not the total number of glands that we have, but I just listed some. We have the adrenal glands, the hypothalamus, where the pituitary glands is. Okay. We have the islet cells in the pancreas. We have the pituitary gland. We have the thyroid. Thyroid gland. So all we are beginning with our first topic under the endocrine system, our first condition under the endocrine system. Okay, let's all pay attention so that we get it once and for all. Okay, all right. So we are beginning with what? Syndrome of inappropriate antidiuretic hormone. Syndrome of inappropriate antidiuretic hormone. Please be quick to listen. Okay, more than trying to write everything. You just follow, listen, and you get the understanding. Okay, very good. So syndrome of inappropriate antidiuretic hormone. First of all, before we can understand the condition, let's first know what the antidiuretic hormone is. Okay, so let's break it down. Let's break the antidiuretic hormone down. So we have anti. Anti means against. Okay, anti means against. And then we have diuretic. Diuretic simply means that the flow of fluid outside the body. Okay, when there is flow of fluid or the ability of the kidney to excrete fluid, that is when you say there is diuresis. When there is flow of fluid from the body, okay, there is diuresis. So this one is anti-diuresis. So meaning this hormone is released basically to fight the flow of fluid from the body. Okay, this hormone is released basically to fight the flow of fluid from your body. That is why we call it the anti-diuretic hormone. Okay, the anti-diuretic hormone. Now we say that, or let me talk about some functions of this hormone. This hormone helps in regulating fluid and water balance. As we will know in the previous slides, or as we move ahead, you realize that this hormone, when there is the disease of this hormone, whereby it is being secreted more, or even it is secreted in an underdose, you realize that it affects your salt and water balance. Okay, it affects your salt and your water balance. So this hormone is released to help with your salt and water balance. It also helps in constricting blood vessels to control your blood pressure. Okay, when this hormone is being released, it constricts blood vessels to control your blood pressure. It also prevents excessive urination at night. Okay, it also prevents excessive urination at night. So when this hormone, in fact, any person who urinates plenty, okay, or maybe you drink more water, you drink more water to the point that you are urinating plenty, this hormone will be released automatically to control how the urine is coming out. Okay, so basically, this hormone is being released to help with what? The control of fluid and then salt balance. And it also helps with BP control. Okay, very good. Now, moving on to this condition, syndrome of inappropriate antidiuretic hormone. We say that it's a condition where there is excess secretion of what? Antidiuretic hormone. There's an excess secretion of this antidiuretic hormone. So this hormone is being released or produced in the hypothalamus. Okay, so let's take note. This hormone is being produced in the hypothalamus and then released into the bloodstream by the pituitary gland. So this condition is a disease of the pituitary gland. Okay, so let's take note. We're talking about the first gland, the pituitary gland. The hormone is produced in the hypothalamus, but then it is released into the bloodstream by what? The pituitary gland. So in an instance whereby the pituitary gland is producing this hormone more or is secreting this hormone more into the blood system, we get what we call what? The syndrome of inappropriate antidiuretic hormone. Okay, a condition whereby the pituitary gland is producing more of the antidiuretic hormone in the bloodstream. They are just producing plenty of them. So when they are being released in the bloodstream, we say there's what? Syndrome of inappropriate antidiuretic hormone. Okay, very good. So the pathophysiology, we say that ADH or antidiuretic hormone, also known as vasopressin. So the other name for ADH is vasopressin. Okay, the other name for ADH is vasopressin. Okay, it's vasopressin. So when ADH, so ADH, also known as vasopressin, regulates water reabsorptions in the kidneys. As I said earlier on, okay, when you are urinating plenty, these hormones should be released by the pituitary gland to regulate or to help with water reabsorption so that you don't pee plenty. Okay, so that you don't pee plenty. Now, when excessive secretion of this ADH is occurring, it causes the kidney to reabsorb too much water. Okay, excessive secretion of this ADH causes the kidney to reabsorb too much water in the kidneys. Then this one will lead to water retention and it will dilute your sodium levels, leading to what? Hyponatremia. So in SIADH, the pituitary gland is producing more. Okay, it is producing more of the ADH, the antidiuresis. You know, once you know the name or the breakdown, it's easy. Antidiuresis, diuresis is flow of fluid, anti against. Okay, so this hormone is against flow of fluid from your body outside. So when this hormone is excreted plenty, okay, the kidney tends to reabsorb too much water because this hormone is plenty. It is not allowing the free flow of water outside your body. Okay, this hormone is not allowing free flow of water outside your body. So it is plenty in your system, and then the kidney will reabsorb too much water. So when this occurs, it will dilute your salt level or your sodium levels, leading to what? Hyponatremia. Please, are you on the same page? Hello.
Yes, please. Yes, please. We are listening.
Very good. Okay, so let's move on to the next slide. Good. So what causes SIADH or what causes syndrome of inappropriate antidiuretic hormone? What causes it? Number one, we have the small cell lung cancer. The small cell lung cancer. Anytime you have this lung cancer, there will be a release of ADH or antidiuretic hormone into your cells, even outside the brain, and it can contribute to what? SIADH. Okay, and then I indicated the ankle stick. Okay, so let me buttress on that one. Usually on your ankles, okay, or most of the times when you get SIADH in a case study, they will begin the history. Most of us who have been using QBank for a while now knows how the case studies looks like. Okay, it begins with a history taking and then it continues. So when you read the history taking very, very well in SIADH, usually or mostly, I can guarantee you about 80% of or 90% of the questions you get on SIADH, usually they begin with a history of lung cancer. Okay, so a patient, you see a history like a patient have been smoking plenty or is a chronic smoker and it has developed lung cancer. Okay, so they have conditions like pneumonia, they have respiratory conditions, they have difficulty breathing. Then, you know, once you read the history, you realize that the patient start presenting with signs and symptoms of SIADH, like weight gain, like fluid overload. Okay, then you should know that the patient have what? SIADH. Okay, once you see, you know, when you are reading history and you see lung cancer as the preceding condition, please be on the alert. Likely they are linking it to what? SIADH. Okay, so please take note. Number one cause or first cause of this condition is the small cell lung cancer. You can also get brain tumors, or brain tumors can also cause lung cancer. We all know where the pituitary gland is. Okay, it is situated below the hypothalamus. The pituitary gland is just below the hypothalamus, and they are all in the brain. Okay, you know the hypothalamus is in the brain. Okay, so when you get brain tumors, whereby there are proliferation of abnormal cells, all these can affect the way the hypothalamus work, and it can cause a release of ADH into the bloodstream. Okay, so you have brain tumors, we have head injury. Head injury can affect your brain. We have COPDs. Okay, that one you can even have a link with the lung cancer. Okay, so COPD can also contribute to what? To SIADH. We have CV, stroke. I'm sure we all know that CV, in fact, the hemorrhagic or the ischemic, they all occur in the brain. Okay, when there's a diminished blood flow to a portion of the brain, and when this thing occurs, usually the portion of the brain will not get enough oxygen and nutrients. So what do you think is going to occur in the hypothalamus? The hypothalamus is also in the brain. So this one can also lead to what? SIADH. We have infections like meningitis. Meningitis is an inflammation of what? Of the meninges. We all know that the meninges covers the brain and the spinal cord, right? The meninges, it covers the brain and the spinal cord. So in a situation whereby the meninges, the covering of the brain has been affected, it will expose the brain to all kinds of infection. You get it? When the meningitis has been, or when the meninge has been inflamed, it will affect the brain because the brain, the protector has been taken away. So it will expose the brain to a lot of things. So when the brain gets infected, it can affect the hypothalamus and it can lead to SIADH. Okay. Medications like carbamazepine or SSRIs can also contribute, or is a cause of SIADH. Okay. When there's a release of when you are taking this kind of medications, they sort of increase the antidiuretic hormone in your bloodstream, and it can contribute to SIADH. Okay, you can also get trauma. Trauma too is a cause of SIADH. Okay, so let's take note. Very good. Now let's talk about the signs and symptoms of SIADH. Okay, signs and symptoms of SIADH. I hope that we all get these electrolyte imbalances once and for all. Okay, because it's kind of confused sometimes. But I hope that by the end of the class, we shall all get the electrolyte imbalances very, very well in these conditions. Okay. So here in SIADH, we have what? Hyponatremia. We have hyponatremia. So you are getting your sodium level less than 135. Or if I may ask, my first question for the day, what is the normal value for sodium? For sodium, please. The normal value for sodium.
135 to
135 to 145.
Okay, very good. 135 to 145.
Yes, please.
Yes, very good. So we are getting what? We are getting hyponatremia over here. So when we close the class, I want you all to do an assignment for me or an experiment for me. Okay, when you close from class, do this experiment for me. Okay, next week I'll ask the person who did the experiment and see what the person got. Okay, whether we are on the same page. So pick a cup. Okay, pick a cup and then pour some salt in it. A salt. Okay, pour just a little amount of salt in it. When you pour it, add little water. Okay, add small content of water or little water to the salt. Then taste it. Dip your hand inside the cup and then place it on your tongue and taste it. Okay, you realize that the salt is too much because the water is not plenty. You realize that the salt is too much because the water is not plenty. Now, add more water to the cup to the point that the cup becomes full. Add plenty water. Don't add too much salt again. Just add more water, okay, so that the cup will become full. And then taste the salt. You realize that the salt content will go down, okay. the salt content or how the concentration of the salt is going to go low. Okay, so it is the same analogy over here. It is the same analogy over here. When you have more water, okay, when you have more water in your system, you know, I said earlier on that SIADH, there's a release of what? The anti-diuretic hormone, okay, and against diuretic hormone. So there's no free flow of water. So there's more reabsorption of water in the kidney. And when there's more reabsorption of water in the kidney, the fluid water or the water content in your cells will also go up. You are going to hold more water. Okay, or simple nursing will say that you become soaked with water. Okay, you become soaked with water. So your system is all about water. Okay, you are walking around and you are just water walking around. Okay, in this condition. So when you have more water in your system, the water will dilute your salt content. Okay, the water will dilute your salt content. When the water dilutes your salt content, the sodium level will go down. That is why we are having the hyponatremia. So you try the experiment. You appreciate what you are trying to explain over here. Okay, there's too much of water in your system. So this water is too much to the point that it's now diluting your salt. So the salt content or the sodium concentration is what is going to go down. That is why we are having what hyponatremia. So on your NCLEX, you see one of these as your laboratory investigations, or let me say your electrolyte checks, and you realize that the sodium level is less than what 135. We also have fluid overload. Of course, there is more ADH. Okay, there's more antidiuretic hormone, so there's no free flow of water. There's more reabsorption of water in the kidney, so there's going to be fluid overload. 3, there is oliguria. Okay, there's going to be oliguria because the ADH is plenty. It is not allowing water to flow out. So the amount of water that's coming is going to be very, very small or scanty. So there's going to be oliguria. There's going to be weight gain. Imagine a situation whereby someone is not bringing water outside. Okay, all water has been stuck in the body. What do you think is going to occur? The patient will continue to increase weight. And we all know that water has weight. Okay, water has weight a lot. So when there's more water in your system, the water concentration or the water level increases, it is going to increase your weight as well. We have cerebral edema. Why do you have cerebral edema? Because of the water content in your cells is plenty. It begins to shift to certain areas. Okay, so it can shift into your brain. And so in SIADH, usually patients do experience cerebral edema because of the fact that the water level in the cells are being shifted into the brain, leading to what? Leading to cerebral edema. Now imagine a situation whereby the brain has been affected. Okay, there is cerebral edema. What do you think is going to occur? Seizures can occur because now how the brain is supposed to function is not there. So there's going to be seizures and there can be headache as well. We can get pulmonary edema. Okay, we can get pulmonary edema. Of course, there is more water in the system. So the water begins to shift from the cells into the lungs, and that one can lead to pulmonary edema. You can get nausea and vomiting. You can also get fatigue. Okay, so all these things are occurring in what? In SIADH. All these things are occurring in SIADH. Okay, very good. Very good. Now we have the diagnosis. Okay, the diagnostic investigations. Okay, the diagnostic investigations. Okay, so usually, especially how our NCLEX questions are being framed on our case studies. Okay, usually when they bring the history, they attach diagnostic investigations to help us diagnose the condition very, very well. Okay, it helps us diagnose the condition very, very well. So in this condition, there's going to be a high urine osmolality. Please, I will explain the point 1 and point 2 at the same time so that we get the understanding. Okay, we have high urine osmolality and then 2, a low serum osmolality. Okay, please get this once and for all. A high urine osmolality and a low serum osmolality. Why? I'm explaining why. Okay, so we have too much water in your system to the point that the antidiuretic hormone is not allowing water to come out of your body. Okay, the hormone has been produced in excess, so it is not allowing water to come out of your body. So what is occurring? There is too much water in your system, and even because of that, the kidney is also reabsorbing too much water, and it's bringing less water out as waste. It's bringing less water out as waste. So what do you think the concentration of water is going to do? It's going to go up. The level of your water the level of water is going to increase in your kidney because there's too much reabsorption. And then, unfortunately for us, the ADH is not also going to allow. It's like a bouncer. Okay, see the ADH as a bouncer. Okay, you go for a party and then the bouncer is at the gate. You want to enter and the bouncer is not allowing you to enter. Okay, so the water in the kidney, and then now the ADH allow you to bring the water. So the kidney act like a bouncer. Let me sorry. The ADH, okay, act like a bouncer on the kidney, not allowing water to flow outside. Okay, so what do you think is going to occur with your urine? There's more water, there's more urine. They are not coming out, so the urine concentration will go up. Okay, the urine concentration will go up because the urine is there, there's more water, waste is piling up. The ADH is telling the kidney, I will not allow you to excrete any water. I will not allow you. I'm acting like a bouncer on you. I'm not allowing you to bring water. So the urine is just there concentrating, and it's concentrating. That is why we have what? A high urine osmolality. Okay. 2, we have a low serum osmolality. Why? It's the same thing. There is too much water. Okay, so once again, let's just imagine this. Imagine a pool of blood. Okay, imagine a pool of blood. You know, blood is very, very thick. Blood is very, very, very thick. Blood is very, very thick. Imagine a pool of blood, and then you pour more water in it. Or let's say you are passing by and you saw that there's a blood at a particular place, and you decided to pour water on it. What do you think is going to occur to the blood? 1, the color will change. You know, the reddish color of the blood. We all know the blood to be red. Okay, when you pour more water on the blood, you realize that the color of the blood, which is red, will begin to fade. It will begin to fade. And then if you even pour more water at a point in time, you are going to wash the blood away. You are not even going to see the blood at all. Okay. So in SIADH, patients have more water in their system. They have more water in their intravascular space. So this water is mixing with the blood and is diluting the blood. So the concentration of your blood is going to go down. That is why we have low serum osmolality. Okay. That is why we have the low serum osmolality. The water is just diluting your blood. It is too much. So it is the blood cannot fight against it. So the water is just diluting it. So we are getting a faded color of the blood, and then the blood is going down. The level is going down. The concentration is going down. We are getting what? A low serum osmolality. Okay. So that is why we have high urine osmolality and low serum osmolality in SIADH. Okay. Today we have a high urine specific gravity. So let's just get this once and for all. Okay. Anytime you are urinating plenty, your urine specific gravity goes down. Anytime you are urinating plenty, the specific gravity goes down. And anytime you are holding fluid, specific gravity goes up. Okay, it's simple. Anytime you are urinating plenty, specific gravity goes down. Anytime you are holding fluid, specific gravity goes up. Okay, so in this patient, specific gravity is going to go up. So I'm asking my next question. What is the normal value for urine specific gravity?
10, 10, 10, 30.
10, 10, 10, 30.
Okay.
So 10, 10, 10, 30. Okay, it's as simple as that. Okay, so 10, 10, 10, 30. Okay, simple as that. 1.010 to 1.030. Okay, 1.010 to 1.030. Okay, someone sent this message in the chat box. 1.005 to 1.030. No problem about it. Okay, you know, when it comes to lab values, to be specific with, many books have different values when it comes to lab values. In fact, books will bring you or will tell you different answers. But do you know something? For the sake of NCLEX, let's keep it between this range. The 10, 10, 10, 30. Okay, 10, 10, 10, 30. 1.010 to 1.030. Please, let's keep it like this for the sake of our NCLEX. Okay, 1.010 to 1.030. So in this condition, the patient will record a specific gravity more than 1.030. Okay, more than 1.030. So that is what we are going to see. Now, 4, we are doing chest X-ray because fluid is going to set from the cells into the lungs, leading to pulmonary edema. So there will be a need for us to do what? A chest X-ray. Okay, there will be a need for us to do a chest X-ray. We are doing CT scan and MRI. Very, very important. The CT scan we can do to visualize how the gland looks like, the pituitary gland looks like. Okay, so you can do a CT scan to visualize how it looks like. Then medical history. Patient is whether patient had meningitis, patient had what? Encephalitis, or patient had a brain tumor. So these medical histories can also guide you the RNs to, or can guide a physician to diagnose what? SAADH. Okay, that is what we are seeing here. Very good. Now let's go to pharmacology. Good. Let's go to pharmacology. So under pharmacology, usually we give them a hypertonic saline. Okay, a hypertonic saline. An example is mannitol. And the mannitol, it really helps with the cerebral edema. Okay, the mannitol really helps with cerebral edema. When it gives the mannitol, it drains all the fluid from the brain, and then the a hypertonic saline, then a 3% what? 3% NaCl. Okay, the 3% NaCl. Usually that is what we give to these patients. Okay, so we are giving them hypertonic saline. 2, we are giving them loop diuretics. Of course, patient is holding fluid. Okay, so you must find a way to counteract that. There is there's a stagnant of fluid in the body. So you must do, or you must try all means to bring out the fluid from the body. So we are doing what? We are giving loop diuretics. Example is the furosemide. Now I'll talk about furosemide a bit for NCLEX interest on furosemide. Okay, when we are giving furosemide on the NCLEX, usually they test you on 2 things. Furosemide on your NCLEX, they test you basically on 2 things. 1, they test you on ototoxicity, and 2, hypokalemia. Okay, 1, ototoxicity, and 2, hypokalemia. So when you are giving furosemide to a patient, and the patient is telling you, Nurse Archimedes, I'm having ringing ears, or I'm having some pains in my ears, then it means that this furosemide is causing that side effect of what? Ototoxicity. So please, let's take note. On your NCLEX, usually when they ask questions of furosemide, they ask based on what? On ototoxicity and then hypokalemia. So furosemide is what? It's a potassium waster. Okay, it wastes potassium. It brings all your potassium level out. So it makes you get hypokalemia. So when you record a potassium level less than 3.5, okay, you know, we all know the normal level for potassium is what? 3.5 to 5.0. So when we are giving furosemide and we start recording potassium level like lower than 3.5, we should know that there is hypokalemia. Then we should respond to the situation. In hypokalemia, what do you do? First of all, you have to do what? Initiate cardiac monitoring. So imagine a question on your NCLEX. Okay, just imagine a question on your NCLEX. You had SIADH. The doctor prescribed what? Furosemide for your patient. And then the patient had hypokalemia because the furosemide was wasting the potassium. Okay, the furosemide was wasting the potassium. And then you get questions on hypokalemia. What are some of the things that you can get as part of our management for hypokalemia? So the question can ask you, as an RN, which of the following should you anticipate? 1, you should anticipate cardiac monitoring. So you put patient on a cardiac monitor, okay? And then you observe for what? For cardiac arrhythmias, because hypokalemia can cause cardiac arrhythmias. So that is why we are initiating the cardiac monitoring, and we are also monitoring for cardiac arrhythmias. 2, you are doing what? You are giving food that are rich in potassium. Or 3, you have to give food that are rich in what? Potassium. So you serve potassium-rich foods. Okay, let's not forget. 4, what do you have to do? You have to give what you call calcium gluconate. Okay, calcium gluconate. You know, calcium is a muscle stabilizer. Anytime you have more calcium, your muscle contractions is like it goes down. Okay, anytime you have too much calcium, the muscle contractions or the way the muscle functions, it goes down. So you have to give calcium gluconate to stabilize the heart to prevent cardiac arrhythmias. Please, I want to make some clarification over here so that we don't make mistakes. Calcium gluconate does not solve hypokalemia. I mean, it does not really correct hypokalemia. No. We give calcium gluconate to stabilize the heart to prevent cardiac arrhythmias. Please, let's get it once and for all. We give calcium gluconate to stabilize the heart to prevent cardiac arrhythmias, but it's not really given to help with the hypokalemic situation. Okay, so please let's take note. So that is some management that we should know when it comes to what? Hypokalemia. Okay, and then once again, because there is a reduction in your potassium level, they can give you an ECG on your NCLEX to identify signs of what, or to help you identify that this is hypokalemia. So on the ECG, you are going to get what, an ST depression and then a U wave. Okay, an ST depression and a U wave. Let me see if we can, what do you call it? Let me see if we can all check the picture of the ECG. Someone said he's late. Okay, so let me see if you can all see hypokalemia ECG. Okay. Very good. So let's see this. Okay. I think this one is a bit okay. Oh, it's taking time to. Very good. It be big. Okay. So let's all check this one. Okay. Let's all check this one. You realize that, oh, let me see if you can open it big. Good. So please let's check this one. Okay. You realize that there's an ST depression. Okay. You see after the KRS complex. Can you all see my screen?
Yes.
Okay. So you realize that after the KRS complex, you see this one after the KRS complex. Usually, you should get a repolarization, okay, or relaxation of the ventricles, okay, here. But now it is slanting, or it has become slanted. Have you seen it? Okay. Just after the KRS complex, it has slanted over here. So that is what we call the ST depression. Okay. So there's a depression. Instead of becoming straight, it has now slanted. And we say there's an ST depression. And then you see this U wave. There's a prominent U wave over here. Okay, it is very, very high. So at least most of the time, or mostly on your NCLEX, when they bring ECG concerning hypokalemia, these two will be present for you to identify it. Okay, these two will be present. So there's a slanted, let me say, after the polarization of the ST segment, there's a slanted region of the ST segment. So you are getting a depression here. So there's ST depression, and then also there's a prominent U wave. They can bring this ECG for you to identify that this is hypokalemia, and then they can bring follow-up questions. Like as I said, you give the calcium gluconate, you give the potassium-rich foods, you initiate cardiac monitoring. Okay, so that is it. Okay, very good. Good. I have a question. If a patient is taking furosemide, can you give the patient insulin?
No.
Why? Can you give the rationale? Why?
Because furosemide is potassium wasting and
Okay.
insulin to bring the potassium down.
Okay. Very good. Very good. So let's take note. Okay, anytime a patient is taking furosemide, you can't give insulin because furosemide wastes potassium. It brings the potassium level down, and then insulin will also shift. It will shift potassium, okay, from your blood to the cell. So it is going to cause. It's going to cause what? Hypokalemia. So you don't combine these two drugs at the same time. Very good. Now the third.
Please, sir,
Yes.
please, I was a bit late. What topic are we discussing?
We are discussing SIADH, syndrome of inappropriate antidiuretic hormone. Okay.
Thank you.
You're welcome. Okay. You're welcome. So
Hello,
the third,
sir.
yes.
Yes, please, I want to find out at which point do we give potassium chloride?
Yes, you can also give potassium chloride as part of management of the condition. If we observe there's hypokalemia, okay. If you observe there's hypokalemia, we can give potassium chloride as part of the management. Let's not forget, okay. So we can give potassium chloride too. Okay.
Hello,
Very
please,
good.
I have a question.
Okay.
Yeah, so something just pop up that if you're giving furosemide, you can't give insulin.
Yes.
Is there a contraindication?
Yes. Okay, because insulin will do what? Will reduce your potassium level. Okay.
Yeah, but
Insulin,
from what I know, what we've been practicing where I am is if somebody comes with congestive heart failure, having bipolar edema, right? And the person is diabetic. In this case, what will you do? Hello? Please, did you hear my question?
hello.
Yeah, a person came with bipolar edema, right? Who is diagnosed of congestive heart failure. This same person is also having a high blood sugar of, let's say, 18. So how are you going to manage this case? Because this patient might need all these two.
Yeah, so every hospital has their policies and protocols they follow, but mostly you can combine these medications for the patient. Okay, you can give
Hello.
furosemide. Hello.
Okay.
Yeah, okay, are you around?
Yeah, you finish.
Okay, so you can give furosemide to reduce the edema. Okay, and then insulin to control the, how do you call it, the sugar. All right, but then you check the sugar level every hour or sometimes 30 minutes, so that you can also be doing electrolytes labs alongside to know the level of potassium. If the level of potassium is always normal, you don't have to give any additional potassium. But if it's down, then you can give the potassium supplement or the potassium, what do you call it?
Potassium chloride.
So that you potassium chloride to control the potassium. Other than that, the insulin can cause the potassium level to go low. All right.
Yes,
so that's what I
exactly.
can say.
Okay, very good. So,
with such patient, you always have to check electrolytes, like the labs. You have to be doing it frequently. Like sometimes they say even every hour, every 1 hour, you have to do electrolytes just to
very
monitor
good.
the potassium level.
It's true.
Especially in DKA. Yeah, someone with DKA.
Okay, I asked this because where I'm practicing as a nurse over here, from the internal medicine, that's what I see them doing. They will give the furosemide and they will put this patient on different IV fluids. One with insulin and one goes with 0.9 with potassium, just to counteract the pushing of potassium causing this hypokalemia. But as said, they always do this electrolyte checks before all this thing, and then the IV insulin is always goes along with perfusion, which is the IV perfuser. So when this came out, I was like, oh, so if it's contraindicated, then mean something's going on here. That's not right. I always want the standard one. That's why I asked the question. I wanted to know which of them is the standard practice.
Okay, hello. Yakut, will you want the answer?
Yeah, I'm just stopping up. Okay.
Okay,
I mean, we
okay,
are all
okay.
on the same page. So I think when you come down here, they mostly do like what you are saying. Okay. Even at my facility, we do that. But it's because of the financial constraints, because doing the labs frequently, most people don't have the money to be doing the labs frequently, to be checking the potassium. So they just start prophylaxis by giving the potassium alongside just to control it.
Exactly. Okay, exactly. So as Yakut said, exactly. We are giving the potassium in an IV fluid just to make sure there's a balance. Okay, so that the distance does not go, the insulin. Okay, the insulin does not waste the potassium that much. But please, you see, let's take note. In a situation whereby the potassium level is very, very, very low, or the potassium is low, when you give the insulin, you worsen the case. Okay. If the potassium level is low and you give the insulin, it can worsen the case. You get it. So let's get it right away from with that, with regards to that explanation. Okay. Very good. All right. Good. All right. So the next drug that usually they give, to patients with SIADH is the vasopressin receptor antagonist. Okay. Please can you all mute up? Madam Rahel, please can you mute up? So we have the vasopressin receptor antagonist, which is the tolvaptan and the conivaptan. Okay. As I said earlier on, vasopressin is another name for SIADH. Okay, it's another name for SIADH. So you have to give a drug that will fight against the it's another name for ADH. Okay, so we just have to give a drug that will fight the ADH to allow the free flow of water. So usually we give the tolvaptan or the conivaptan. Okay, so let's not forget, we can see this drug on our NCLEX as an antagonist to what, or a drug we usually prescribe in SIADH. 2, and then the last one, we can also give domiclocycline. Okay, the domiclocycline, you can also give it. Do you know what this drug do? The domiclocycline works by inhibiting or blocking the effect of the ADH on your renal tubules. Usually, okay, the domiclocycline works by blocking the effect of the ADH on your renal tubules. So when you give this drug to a patient with SIADH, what you are doing is that you are blocking the effect of the ADH or the antidiuretic hormone on the kidney to allow the free flow of what? Of blood, of urine. Okay, very good. The nursing interventions, there are fluid restrictions, usually less than 800 ml per day. Okay, so these patients, usually there's too much water in their system already. So what do you have to do? You have to restrict fluid. There is more of the antidiuretic hormone to the point that the patient is not bringing water out. So why do you have to top up? You don't have to top up. You have to restrict fluid. So they can consume less than 800 ml of water in a day. Okay, and then 2, intake and output. You have to be recording your intake and output. Why? You are going to give furosemide at the long run. So there's going to be a fluid coming out, and you're also giving hypertonic saline. So you must do what? Measure your intake and output very, very well. We are giving them what? Oral salt tablets. This one is clear. There is dilutional hyponatremia. There's too much water diluting your salt. So you must give them what? Oral salt tablets. You monitor for hypokalemia, as I said earlier on. You monitor for hypokalemia because the potassium level will go down when you start the furosemide. Okay, so you must monitor for hypokalemia. You monitor patient signs, vital signs, especially the blood pressure. Yes, these patients, because they are holding fluid a lot, especially in the SIADH stage, okay, when they are holding fluid a lot, because they are holding fluid a lot, it will increase the intravascular volume. This will increase your patient blood pressure. Okay, so that is why you are doing what? You are monitoring the patient blood pressure very, very well to prevent any hypertension. You monitor patient weight daily. You monitor patient weight daily. And on our NCLEX, this is how they frame the word. You monitor patient weight daily with the same weighing scale and then with the same what? Clothing. Monitor the patient weight daily with the same weighing scale and with the same clothing, because this patient is going to increase weight. There is water in the body. They are having water stuck in the body, so automatically they will going to increase their weight. You institute straight seizure precautions. Of course, fluid will shift into the brain, causing what? Cerebral edema. When cerebral edema occurs, it can cause seizure because the electrical conductivity of the brain becomes impaired and can lead to seizure. So you must institute what? Straight seizure precautions. You have to raise your side rails. You must bring your side rails up. You must do what? If seizure occurs, you put patient in a side-lying position. Okay, you put patient in a side-lying position. Because of the drooling, there can be an indication for us to do suctioning on this patient because of the seizures. Okay, so you suction as when it is necessary. So all these things should be factored in when it comes to the seizure precaution. You perform frequent neurological checks. Of course, there's fluid in the brain, so you must check the neurological functioning very, very well. It should be frequent. So these are some of the next interventions that you must do to rescue the situation. Okay. Good. Then we have surgical intervention. Okay, so earlier on I said that the what do you call it? The ADH is released into the bloodstream by a particular gland. Who can remind us which gland releases the ADH into the bloodstream?
It's pituitary.
Pituitary gland. Okay, very good. So if it's the pituitary gland, okay, if it's a pituitary gland and the pituitary gland is releasing more of the ADH, we are trying our tolvaptans, we are trying our nursing interventions, and it has gotten to the situation whereby it looks like the condition is not really hot, or it is not really having a good prognosis, and it's not resolving. We have to do a surgical removal of the pituitary gland, okay? Because it is this gland that is producing more of the ADH. So what do you have to do? To solve the situation, let's just take it off so that the patient will be free. So we do what we call the transsphenoidal hypophyseectomy. The transsphenoidal hypophyseectomy. So we go straight into the brain and then we bring the pituitary gland out. So it's a surgical procedure done to remove what? The pituitary gland, which is what? Called a transsphenoidal hypophyseectomy. Let me pass this across. Please, when you are studying for our NCLEX, usually surgical interventions or surgeries, the questions are mostly on the post-op management. Please, let's take note. Mostly the questions are on the post-op management. Usually the questions are on the post-op management. You can get a bit of pre-op, okay? You can get a bit of pre-op, but usually pre-op is not that much. Okay, you get the mostly you get the post-op management questions more than the pre-ops, and then the intra-op is not our case. We are not surgeons, okay? So the intra-op is the issue of the surgeons. We are nurses. We prepare patients, and after the patient comes, we manage. So ours is the pre-op and the post. And I'm saying that even between the pre-op and the post, usually they test us more on the post-op management. Okay, very good. So after the surgery has been done, these are some of the things that the RN must take note of. You monitor for what? Cerebrospinal fluid leakage. Okay. And then there will be a formation of halo sign on the dressing. And then the drainage will test positive for glucose. So after the surgery has been done, you know we are going to the brain. Okay, you are going to the pituitary gland. The pituitary gland is just below the hypothalamus. They are all in the brain. Okay. So we are going there to bring out the gland. And then because we can tamper with the cerebrospinal fluid, after the surgery has been done, you have to be observing for the leakage of the fluid. So you realize that there's a halo sign, okay? There's a halo sign on the dressing. Then it means that there is what? There is cerebrospinal fluid leakage, or the fluid that is coming out, it is testing positive for glucose, okay? It is testing positive for glucose. Then we can conclude that this is what? A cerebrospinal fluid what? Leakage. 2, we avoid, yes.
Please, the halo sign, is it the same as the formation of concentric ring?
Yeah, the ring one. Yes, I was even going to say it. Okay. So it's the same thing. Yeah, the ring one. So you it is around, let me see if we can even check it. Okay. The halo sign. Let me see if I can show a picture of it. It is a bit red. Okay. Let me say round, something like a round. Let me see if we can. It's here. Have we seen it? It is very, very round. So it's like a ring, something. Okay. So usually they call it concentrated ring or the halo sign. Okay. So this is how it looks like. So let's take note. Okay. And once we see this on the dressing, it means that there's a cerebrospinal fluid leakage.
Miss, we can't see it too. Are you showing something?
Oh, you can't see it.
Yes.
No.
But can you see this?
The slide is still on.
Can you see this? Can
We
you all
see
see
the slide.
Oh, okay.
Yes.
Can you see the screen, the image now?
No.
Oh, wow. Let me check. Okay. Please, can you see now?
No, no. We can't see anything.
You can't see anything.
No.
Not even a slide.
It's the slide that is keeping on changing.
Oh, what is occurring to my screen? Okay. Let me see. Hope you can see now.
Okay.
Yes.
We can see now.
Very good. So this is what we call the halo sign, okay, or the concentrated ring. So please let's take note. Once we see this sign, it is an indication of what? Of cerebrospinal fluid leakage. Okay. Once we see this sign, it's an indicator of cerebrospinal fluid leakage. Okay. Very good. So that is it.
Okay.
Yes, you are welcome. Okay. Very good. So let's move on to let me see. Two, you have to avoid what? You have to avoid activity that's increase intracranial pressure. Because you went to the brain, you must avoid activities that do what? Yes, hello.
So I wanted to find out the CSF that you see on the halo ring. Will you take a sample to check for the blood glucose?
Yes, exactly.
So you open the dressing or?
Yes, there's the fluid that is on the dressing. You just take a slight one on it, okay, and then you test for the glucose. Okay.
Okay. Yeah, thank you.
Yes, good. So you have to avoid activities that increase intracranial pressure because we have gone to the brain. Okay, so that the likelihood that you increase intracranial pressure is very, very high. So you must avoid activities like coughing, like straining, like sneezing. Okay, even you have to blow the nose very, very gently to prevent the increase in intracranial pressure. Okay, then the patient must be on a lifelong hormone therapy. Okay, you will get there very soon on DI or diabetes insipidus. Okay, because the pituitary gland has been taken off. This gland is what produces ADH into the bloodstream. Now, this gland has been taken off, meaning that we're not going to get ADH at all. So after the procedure, what do you have to do? You have to give a lifelong artificial ADH to the patient, okay? So the patient must be on a lifelong AntiDiuretic hormone because now the gland has been taken away. So you must give an artificial ADH, okay? Very good. Then you elevate the head on 2 pillows or more. Okay, they lie in a supine position, and then you place 2 pillows or more under their head, and then it keeps it elevated. Okay, very good. Now we can have some complications. Okay, cerebral edema, I was talking about it. Then DI, diabetes insipidus. We'll go to it very soon. Okay, so diabetes insipidus because the ADH is no longer there. So the drug or the hormone that is supposed to hold the fluid is no longer there. So there will be just outflow of fluid. So there's going to be DI. There can be coma if there's too much water in your brain. Imagine a situation where there's too much water in your brain. Oxygen delivery to the brain is impaired. You get it? Because the water has just clamped your brain. So even oxygen delivery is impaired, and this can lead to what? Coma. You can get respiratory failure because there is pulmonary edema. Water has shifted into the lungs, so that we can get respiratory failure. So in such instance, we have to support the patient with oxygen, okay, to support the situation. We can also get cardiac arrest, okay. So that is that for SIADH. Please, do you have any question? Please, do you have any question?
Yes, sir.
Okay.
Please,
Hello, please.
I want to take you back a little. Please,
Okay.
you said we can give hypertonic saline.
Yes.
Well, we are supposed to reduce fluid intake. So
Yes.
please explain the two to me.
Okay. We are reducing fluid intake, but then we are not, I mean, what do you call it? Restricting fluid at all. So please, let's get it, okay? Even though this patient, we are reducing it, we are not stopping. We are not, I mean, stopping fluid intake at all. You get it? We are not stopping the fluid intake at all. So we can give them the hypertonic saline to help with what? The reduction of what? The reduction of the fluid. And you know, this hypertonic saline, it really works well by shifting the water from the intravascular space to come out from the kidney. Okay. Once we give the hypertonic saline, it helps in really shifting the fluid over from the intravascular space and bringing it through the kidneys. Okay, so that is why we give the hypertonic saline. Hypertonic saline will even help with the shifting of the fluid so that it can now be excreted. Okay, that is why we give the hypertonic saline. Okay.
Okay, thank you.
You're welcome. Please, any other question?
Yes, please. Apart from the hypertonic saline, is there any other thing we do to manage the hyponatremia actively?
So oral salt.
Yes, oral salt tablets can be given. Okay. The oral salt tablets can be given to help the patient as well. Let's not forget. Okay. Or we begin to give patients diet that is rich in salt or sodium. Okay. You can increase patient food or diet that is rich in salt, okay, or sodium. So that is what we can do. Okay. Very good. Yes, someone raised the hand. Maria.
Yeah, so for the hypertonic saline, is it strictly 3% hypertonic saline?
Yeah, usually the hypertonic saline is the answer or the example that we usually get, or we usually have what they usually give is the 3% hypertonic saline, usually. Okay. Or an example of it is the 3% NaCl. Okay. 3% NaCl. So usually that is what they usually give. Or another example is a monitor. Okay. They usually give this medications to help with the reduction of the fluid levels in the patient system. Okay. So let's not forget. All right. Please, is there any other question? Okay. All right. Okay. All right. So we are moving on to diabetes insipidus. Okay. And this condition, I will not waste much time because it's the opposite of SIADH. Okay. Diabetes insipidus is the opposite of what? SIADH. It's just the opposite. So we are getting an under-secretion of what? The antidiuretic hormone. In SIADH, we have more production of the antidiuretic hormone. Here, we are getting an under-secretion of the SIADH. So in the antidiuretic hormone. So in the SIADH, what was occurring? Fluid was being built up, okay, in SIADH. So in this patient will lose fluid rather, okay. In the SIADH, fluid was just building up, was just piling up. It was just piling up. But because here the ADH is not producing, the bouncer, okay, so let's go back to the party story I said. So you are going to the party and then the bouncer was stopping you. So the bouncer was the ADH. It is stopping you to go inside. It is stopping you, the kidney, to bring fluid outside. Okay. Now the bouncer said that I'm going away, so you can now have free flow. You get it? So now the ADH in DI, the bouncer of the kidney is no longer there. So now the kidney is just bringing water. There's no reabsorption of water in the kidney. Okay, there's no reabsorption. So the bouncer just left the gate. So now everybody can enter. So now fluid is just flowing, it's just coming out. Okay, just like that. That is what we are getting in what? In DI. But we have two types of the DI. We have the central DI and the nephrogenic DI. It is very, very important that we know the difference. The central DI, as the name suggests, okay, central DI, it means what? Central nervous system. Central DI, it means central nervous system. So the brain. So this one, there's an insufficient hormone production in the hypothalamus, in the brain, for the central DI. But then the nephrogenic, the brain is functioning well. There is more production of ADH in the hypothalamus. In fact, the pituitary gland is excreting more, or is excreting enough of the ADH. It is just that there are problems in the kidney, nephrons, nephrogenic. So this one, the problem is in the kidney. There are issues in the kidney to the point that the kidney cannot be sensitive to what? To the ADH to hold water. So that is the difference between the two. In the central DI, the problem is in the brain. Okay, the brain is not producing enough from the hypothalamus. But in the nephrogenic, there's nothing wrong. The brain is producing as it has to produce. But then when it gets to the brain, when it gets to the kidney, there is insensitivity to the kidney to the ADH, so they can't hold water, and the water will still come out. Okay, so that is the difference between the two types of what? Central diabetic insipidus. Okay, very good. So here too, we have causes like the head trauma, brain tumors, infections, surgeries like surgeries like transvagal hypophyseectomy. Okay, we have genetics, we have kidney diseases, we have medications. Okay, medications like what? Tolvaptan. So when you give too much of the tolvaptan, you are going to push patient into what? Into DI. So head trauma, brain tumors, there's cancerous cells in the brain, and this is preventing the hypothalamus from producing enough ADH. Okay, there are infections, meningitis. So the meninges is broken down, it is exposing the brain. This can cause infection in the brain, and it can cause the release or an under secretion of what? Of the ADH. Okay, we have pituitary surgeries like transvagal hypophyseectomy, kidney diseases. Okay, so conditions like glomerulonephritis can really affect or can really cause ADH, because in this instance, the kidneys are being affected. Okay, or pyelonephritis, the kidneys are being affected. So even when the ADH are being released, the kidneys is not responding to the ADH very, very well. So they can be DI. Okay, very good. So the signs and symptoms here, we have polyuria, polydipsia, and then we have nocturia. Now, let me lay some emphasis here. Okay, let me lay some emphasis here. Please, don't let them trick you with diabetes mellitus, because you see, in both diabetes mellitus and diabetes insipidus, we all have polyuria, we have polydipsia, and there can be nocturia in all of these conditions. One thing that should help you is that in diabetes insipidus or in DI, there's nothing of relation with the blood glucose. Please, let's take note. There's nothing of relation with the blood glucose, so don't let them trick you. Okay, in diabetes insipidus, there's nothing of relation with the blood glucose. So even though you are getting polyuria, you are getting polydipsia, you are getting nocturia, there's nothing really wrong with the glucose. It is just that the bouncer is not there. The ADH that is supposed to be released to help the kidney reabsorb water is not there. So now the kidney is just bringing water just like that. That is why you are getting the polyuria. And because there's polyuria, there must be a compensatory mechanism. The brain will be stimulated for you to drink more water to replace what you are losing. That is why we have polydipsia. And then you can get nighttime urination. Okay. 4, we have hypotension. Because we are losing more water, you are going to get a depletion of intravascular volume fluid. Okay, we are bringing more water out, so there's going to be a depletion of intravascular fluid volume. So this will lead to hypotension. Now, the moment there is hypotension, what is going to occur? I have to compensate. Hey, I'm losing water. So the brain will be speaking to itself, Charlie, water is going out. I'm losing fluid. The intravascular volume is less. So Charlie, I have to compensate. Okay, so I have to pump, or the heart must work harder to ensure that there's adequate blood pressure against your arteries. Okay, anytime there is fluid volume deficit, likelihood you are going to get hypotension, because there is less fluid volume in the intravascular space to circulate for blood flow. Okay, So this alone will cause hypotension, and the body have to compensate to work faster, or the heart will have to compensate to work faster to supply what blood, and this will cause tachycardia. Okay, we have weak and thready pulse. We have weight loss. Weak and thready pulse because of dehydration. This patient is losing more water, so there's going to be dehydration, of course. You are going to get weak and thready pulse. There's going to be weight loss. Okay, of course. Opposite of SIDH. And SIDH, you are holding more water, so there's weight gain. Here you are losing more water, so there's weight loss. Okay, we have fatigue. We can get headache, and we can also get what? Dry mouth. So all these are signs and symptoms of what? SIADH. Sorry, DI. Signs of DI. Okay, signs of the symptoms of DI. Now we have medical history as a diagnosis. Okay, so when we want to diagnose the patient, we can use the medical history to diagnose the patient. We can use physical examination to diagnose the patient. Now, the major one is the urinalysis. Okay, urinalysis. So I'm asking this question: can someone tell me what is going to occur for the urine specific gravity and then the osmolality? Are you going to get a high urine osmolality or a low urine osmolality?
We are going to get a low.
A low one.
Very good. And what will occur to the specific gravity? The urine specific gravity?
It's also
high.
low.
Increase.
That one will increase.
That one will increase. Okay.
Decrease.
No, it will not decrease. Will it decrease?
It will
No.
increase.
It will increase. It will increase.
Increase.
Relax. Oh. Let's relax. Okay. Will it increase or will it decrease? Let me ask this question again. Will the specific gravity increase or decrease?
It will increase.
It will decrease.
Are you sure?
It will decrease. Concentration will be low. So
It will decrease.
Very good.
Yeah.
Very good. Okay, so I said this in the SIDH. Anytime you're urinating plenty, specific gravity goes down. Okay.
Yes.
Anytime you're urinating plenty, specific gravity goes down. And anytime you're holding fluid, specific gravity goes up. So in SID, specific gravity will go up, but in DI, it will go down. Okay, let's take it once and for all, because the concentration of the urine is going to go down. Okay, the concentration of the urine is going to go down. So this one, anytime you're urinating plenty, okay, the specific gravity goes down. Anytime you're holding fluid, it goes up. So you're going to get a low a specific gravity, right? And then a low urine osmolality. What will happen to the serum? What will happen to the serum?
It will increase.
It will increase. Okay, why? Someone should tell us why.
Low fluid concentration.
Because there will be thickness of blood.
Very good.
Because kidney is not reabsorbing any fluid at all.
So the concentration of your blood will go up. Okay. You are just bringing more out water. So the blood will just be concentrated. The blood will be thick. Okay. The blood is going to be thick. So you are not going to get enough water to dilute it. That is what is going to occur in the osmolality. It's good that we are getting the understanding very, very well. Okay. Good. You can do blood test. You can do electrolyte and then the glucose. Okay. You can do electrolyte and then the glucose. The electrolyte, you are going to get what? The sodium level in this instance is going to do what? What is going to happen to the sodium level here?
To go up.
Increase.
Okay. Hyponatremia. So you are bringing just water out. Okay. You are bringing water out, and it's going to be left with sodium or salt in your body. So leading to what? Leading to hyponatremia. Okay. Very good. We can also do water deprivation test, and we can do CT scan and MRI as well to check the pituitary gland also. Okay, so basically, these are our major diagnostic tests. Usually on your ankles, you are going to see the specific gravity for the urine. You are going to see the osmolality for the serum and then the urine. Please, let's take note. Okay, it is very, very important. The specific gravity, the osmolality for the urine, and then for the serum. That is why I explained it well, so that and by now I'm sure we all gotten it very well. Okay, very good. Yes.
Please, how is the water deprivation test done?
Oh, okay. Hello.
Oh, depends.
How is the water deprivation test done?
Okay. Okay, so this one, the water deprivation test, it's a diagnostic test that they usually do to evaluate the body's ability to concentrate urine, okay, in conditions like DI. So it's a whole procedure, okay, it's a whole procedure, but then to summarize it, the patient will even sign a consent form, okay, the patient will even sign a consent form. Let me just go to the procedure. So you measure the patient's weight, their blood pressure, specific gravity, and then you start the test. Okay, so you deprive the patient of water for usually 8 to 12 hours. So you're not giving anything, you're not giving any water to the patient. Okay. You deprive the patient water for like 8 to 12 hours. Now, the patient's urine is collected at regular intervals. Okay. During the deprivation stage. So once you are depriving the water for like 8 to 12 hours, for like 2 to 3 hours, you take the urine sample. You take a urine sample between at any 2 hours interval. You take the urine sample. Okay. Then you measure the urine specific gravity at every interval. So you deprive the patient water for 8 to 12 hours, and then within the 8 hours, 8 to 12 hours, you are taking urine sample for urine specific gravity at every 2 hours interval. Okay, very good. So the interpretation, how you interpret it, in the normal individual, the urine specific gravity will increase during the test period as the body concentrates the urine. Okay, the urine specific gravity will increase as the body concentrates the urine. Now, in a patient with DI, the specific gravity is going to go low. Okay, so this test is simple. We are just depriving you of water, and then we take the urine sample within that period to do what? To check urine specific gravity level. If you have DI, specific gravity is going to do what? It's going to go down. And then if you don't have DI, the specific gravity is going to go up. Okay, are we okay?
Thank you.
Yes, you're welcome. You're welcome. Okay, yes, Mr.
Hello, sir.
Francis, saw a hand up. Yes.
Please, what about the glucose tests? So that we don't confuse ourselves with diabetes.
Okay, you are doing the glucose to just confirm that this is DI and not diabetes. Okay, in diabetes, glucose level is going to go up, right? But this patient, usually they have a normal glucose level. So that is what you are going to observe. They usually have a normal glucose level. And that will let you know that this is not diabetes. It is rather DI. Okay. Yes.
Okay.
Yes. Yeah, I saw a hand up. I said Francis also.
Yes, sir. Please. I also wanted to talk about this in the glucose because we talked about the electrolytes. So I didn't hear about the glucose. So I wanted to find out whether.
So yeah, you're okay now.
Whether it should be. Yes, please. Yes.
Okay. All right. Yes, I
Yeah,
can
so
see.
please the glucose, are we using the urine dipstick or we are using the blood glucose?
Yeah, we can do both of them. You can do both of them. Okay. Okay, you can do both of them to confirm. All right. Yes, Madam Abdullah. Is it Abdullah? Sorry if I don't mention him right. Okay.
Yes.
Abdullah. Yes. You raise your hand, please. Any question?
Yes. No problem. So meaning there'll be doesn't hello?
Yes.
Does it mean there'll be hyperkalemia in DI?
In DI, you are urinating plenty.
Hyperkalemia.
In DI, you are urinating plenty. So what do you think is going to occur? The potassium, the kidney is excreting more potassium, okay, because of the DI. There's going to be hypokalemia. Let's not forget, as a memory trick, okay, this is a memory trick. Anytime sodium is high, potassium is low. Anytime potassium is high, sodium is low. Okay, so this is a memory trick. So in DI, what do we have? We have hypernatremia. So obviously, there's going to be hypokalemia. Okay, all right. Please, are we okay?
Yes, please.
All right, so let's move on. Okay, let's move on. So pharmacology, we give them the desmopressin and the vasopressin. Okay, so the desmopressin is an artificial ADH. Usually, this is what they prescribe for the patient. Okay, desmopressin is an artificial ADH, and then they will prescribe this drug. Now, please take note, even though we can give vasopressin, on your NCLEX, if you see a question, and the question is like, between desmopressin and vasopressin, what should you give? Please pick the desmopressin over the vasopressin. I have seen a question like that. That is why I'm chipping this in. The options, they brought vasopressin and then desmopressin. And then the answer was the desmopressin, because the rationale they gave was that the vasopressin, it can cause severe hypertension. It really have vasoconstrictive properties to the point that it begins to constrict blood vessels. That can lead to hypertension and even stroke. Okay, so instead of giving the vasopressin, you have to give the desmopressin ahead of the vasopressin. Okay, so that is something that we should know. And then you are giving diuretics in the nephrogenic DI. Please take note, this patient is losing water, but still in nephrogenic DI, not central DI. We don't give diuretics in central DI, but we can give diuretics, especially the thiazide ones, in nephrogenic DI. Okay, we can give thiazide diuretics in nephrogenic DI. So please, let's take note. It is believed that when you give thiazide diuretics, it will concentrate fluid, or it even help with the absorption of water and salt in the kidneys, and therefore it will prevent the excessive flow of water. That is why we are giving the thiazide diuretics, and together with the potassium sparing diuretics. These ones can be given in nephrogenic DI. Yes, Madam, please.
Yes, please. What's the difference between the central DI and the nephrotic DI?
Please, can someone answer here? I think I said it earlier on. Can someone help here?
Please. You said the central DI is coming from the brain. It has something to do. The brain is not stable. The brain is not able to produce the ADH. While that of the nephrogenic is due to the hormone is there, but they are not sensitive to the kidneys are not sensitive to the hormone. Due to that, they are not able to concentrate the urine. So I will link it with, like, we have diabetes type 1 and type 2. That's how, if you want to remember this things, central DI and that of the nephrogenic, you look at them like the type 1, that is with the insulin. The insulin is not there. It's not there. So you have to give insulin to pick it to the cells. Whilst the type 2, the insulin is there, but the cells are not sensitive. So it's like the nephrogenic. The cells are not sensitive to pick the hormone. So that you get it. The kidney, the same thing as cells. The kidney cells, we can put it that way if you want.
Very good. That is
Thank
it.
you.
Exactly. Thank you so much.
Okay,
Madam.
hello.
Yes.
Hello.
Yes.
So with what she said, does it mean with the central diabetes insipidus, you give the desmopressin and the vasopressin, but with the nephrogenic one, you give the diuretics?
But yes. In the central DI, the desmopressin and vasopressin works very, very well. But please take note too, we can still give the desmopressin and nephrogenic DI. Okay, we can still give, but it's usually that the thiazide diuretics are being given in the nephrogenic as well. We can add the thiazide diuretics in the nephrogenic medications to also help with the fluid retentions. Okay, so it is like we can combine them. Okay, we can give the thiazide diuretics or the desmopressin, but in the central DI, don't ever try to even give a diuretics. It's not going to do anything, and you're even going to worsen the case. Okay, so that is it.
Okay.
Yeah, please. I missed the explanation you gave concerning the thiazide diuretics, the rationale.
I said that the thiazide diuretics, in fact, if you even research on it, they will tell you that it is not really clear. Okay, but then it's believed that when you give thiazide diuretics, for example, to be specific, the free flow of water. Okay, so once you give the what do you call it, the nephrogenic DI, once you give the nephrogenic DI, once you give the thiazide diuretics in nephrogenic DI, it has a way of reabsorbing water and salt in the kidneys and thereby causing fluid retention and correcting DI. Okay. Are you okay, please? Hello. Hello.
Yes, we are.
Okay. All right. Very good. So now let's talk about the next interventions. So this patient, of course, the patient is losing water. So you have to give IV fluids. Example is the hypotonic fluids. Okay. You give hypotonic fluids in this instance. So you are replacing fluid. You have to avoid excessive caffeine and alcohol. Okay. You have to avoid excessive caffeine and alcohol because this patient already has an issue with their brains and all this stuff. So why do you have to give alcohol in this place? You have to monitor urine output. Okay. You have to monitor urine out because the patient is bringing more water outside. And then even you are also going to give IV fluid. So you have to monitor the urine output. You wear a medical bracelet. Please, let's take note. This patient, they have to wear a medical alert bracelet or jewelry. Okay. You monitor patient's weight daily. It's very, very important because this patient is going to do what? It's going to lose weight because of the free flow of water. They are losing water every day. So it can affect their weight. So you must monitor the patient's weight daily. Observe for hypokalemia and then observe for hypernatremia. Hypernatremia because there's just free flow of water, leaving the body with more sodium. And then because the kidney is excreting more potassium, do you know something? Potassium is largely excreted by the kidney. Potassium is largely excreted by the kidney. So in an instance whereby there is a condition whereby it's causing more urine flow, the potassium will follow, leading to hypokalemia. Okay, very good. So now the complications are here. We have dehydration, electrolyte imbalances. I said it. We have hyponatremia, hypokalemia. You can get hypovolemic shock. Of course, you are losing water, so you can get hypovolemia. You can lead to hypovolemic shock. Okay, you can get kidney damage, and you can also get seizures. Okay, so all these are some of the complications that you should be expecting when a patient have what? DI. Okay, please, are you okay? Are we good? Any question? We are done. We are going to some questions. I have some questions here.
Hello, Bosaki.
Yes.
Please, let me take you back small. I'm so confused with the thiazide diuretics.
Okay.
Because the person is losing
water,
a lot of urine, yes. And
I
then
know,
now,
right? I know, right? Yeah. So, this question. I remember when I was preparing for NCLEX. Okay, about some years and months ago, I saw this question somewhere. In fact, I bargained with the question and bargained with the question and bargained with the question. The answer was hydrochlorothiazide, a patient with nephrogenic DI. They stated it clearly. Nephrogenic DI, which of the following drug would you anticipate? And the answer was there, hydrochlorothiazide. I was confused, okay, till I got to know this. Okay. Please, you can give thiazide diuretics in nephrogenic DI. The rationale is that thiazide diuretics like hydrochlorothiazide has a way, okay, it has a way of concentrating the urine and also reabsorbing salt and water in the kidney. Okay, so this can control the fluid outflow. Okay, so let's take it like that. Okay,
we'll take it like that. Thank you.
You're welcome. Even, I have researched this several times, and then the information I get, they keep on telling me that it is not even clear. The rationale is not even clear, just that it can help to hold fluid. Okay, so we go by that. Okay.
Okay.
Sorry,
right.
please, I need clarification. Please, do you mean we can give the desmopressin in both cases, in the central and then the other one?
Nephrogenic.
No, the desmopressin. Can we give it in the central?
Yes, you can give it. Desmopressin, we are giving it in central.
Yes.
Okay. So we can give it in central and the nephrogenic as well, right?
Usually they give the desmopressin usually in the central DI, and the vasopressin they give that one in the central DI. Okay, and then the nephrogenic usually they give the thiazide diuretics. Okay. They give a thiazide diuretics more often in the nephrogenic. So you can give thiazide diuretics, the DIM, the nephrogenic one. You can give thiazide diuretics. You can give what you call the endomethacin. Okay, that drug, like it's an NSAID drug, it can also help. So that is what they usually do for these two. Okay, very good.
Thank
All
you.
right. You're welcome.
I have a question.
Okay, you can ask. Please.
You made mention of hypovolemic shock in DI.
Yes.
Is that also going to happen in SIDH?
Usually, no. In SIDH, there is more water. Okay.
Fluids.
There's more fluid. You know, in SIDH, there's more fluid. Okay, so there's more water in the intravascular space. So this patient will never go hypo. There's more water. But in DI, you are losing water. You are just urinating. You are peeing here and there. All the water is coming out. So obviously, you are going to go hypovolemia. And then I need to have volemic shock.
I asked that because what happens also in ascites? I asked that because what also happens in ascites? Can you clarify that one for me? Because
ascites, there's a fluid shift into the tissues. Okay, there's a fluid shift into your tissues. That is what goes into the ascites. So in ascites, all your fluid level is moving from your cells into your tissue. So you are getting edema. That is what goes into ascites. Okay, that's what goes into ascites.
So if ascites, you can have hypovolemic shock in ascites.
Ascites, because they are having more tissues, because they are having more fluid in the tissues, they are rather getting more fluid. Okay, they are getting more fluid. They are rather increasing more fluid because they're getting their fluid in the tissue.
I asked because I think there was something that Gia was teaching us where this thing came up. Because I'll be glad if you use the ICF, the ECF, and the interstitial space to explain this one more clear, shifting of fluid from this to that and that to that. Because he made mention of something like ascites. I stand to be corrected, but ascites in relation to hypovolemic shock because there will be fluid shift from the ICF to the interstitial. Though the body is retaining water, it's not the water accumulation is to the wrong space, causing dehydration to the other space. So whether the ICF, which he made mention of that. So I want a whole clarification over that one.
Okay. Let me see if I can project this one. Okay.
I don't know if you understand my question.
Yes, you are trying to figure out what goes into IV fluids and their shiftings, right?
Yes, in terms of, because I know that was what was taught, that ascites, the question that came up, that was
sometimes patient, yes, ascites, patient is causing, there's a fluid shift from the thoracic space to the tissues. Okay, so that is going to reduce the fluid volume intravascular space. Okay, obviously it's going to reduce the intravascular space, and I think that can contribute to hypovolemia. Yes, it can contribute to hypovolemia. Okay. Yes.
So now what happens to the SIDH2?
SIDH is the same. In SIDH, you have more water in your intravascular space. Okay. You are having more water in your intravascular space.
That's the ICF?
Yes.
Oh, okay.
Yes. So that is why you are having more water. When there's more water, you don't go hypovolemia. Okay.
I'm good now. I'm okay now.
Okay. All right. Please, are we getting it? So please let me just clarify it, or let me emphasize on it once again. In ascites, you are losing water from the intravascular space into your tissue. So you are going to be diminished. You are going to have diminished water in intravascular volume. That can cause hypovolemia. Okay. But then in SIADH, you are having more water. You are having more water in intravascular space. Okay. And interstitial space. This can increase your fluid volume. So this patient will not go hypovolemia. Okay. All right.
All right then.
Good. All right. So I have this question on the yes, a hand is up. Yes, Pluto. Your name is Pluto.
Yes, sir. Please back to the DI.
Okay.
Regards to the potassium sparing diuretics and the thiazide diuretics that you stated. It occurs to me like that is sort of try to address the issue of the what is it called? Hypotension in the DI. Because the potassium sparing will spare potassium, right? So that it will not be lost. And then the thiazide diuretic will also spare calcium. Both will help in the in stabilizing the BP.
Okay.
Yeah.
Okay.
So that is what I have to add.
Okay. So you just wanted to make addition. Okay. Thank you very much for the addition. Okay.
You're
All right.
welcome.
I'm grateful for that. Okay. Good. Let's please any other question, please. Any other question? Oh, we are ready to answer the questions. Okay, so this is the first question. Please, I hope you can all see the screen and we can all read the question.
Yes, please.
Okay, so let's pick an answer. Okay, the nurse is planning post-op care for a patient who is being admitted to the surgical unit for a recovery of transperineal resection of the pituitary tumor. Okay, which nursing action should be included? Palpate extremities for edema, measure urine volume every hour, check hematocrit level, and monitor continuous pulse oximetry for 24 hours. Which answer are we going for?
We measure urine volume every hour.
Okay, why?
Why?
Yes,
you know,
why?
the pituitary gland is responsible for release of the ADH.
Okay.
So if there's a problem with it and they are going to do surgery, you want to monitor to ensure balance so that they will not how will I say?
No, you're on the right track. Okay. Yes, it's the same. Okay. Yes, all right.
Okay.
Any other answer or rationale?
Yes.
Okay.
Also, the patient is at risk of diabetes insipidus.
Very good. Okay, because you have taken away the pituitary gland. Okay, so let's read the rationale. So the answer is B. Okay, after pituitary surgery, the patient is at risk for diabetes insipidus caused by cerebral edema. Okay, monitor the urine output and urine specific gravity is essential. Okay, so the answer is B because you've taken away the pituitary gland. There's no ADH, so you have to monitor the urine output. It's what is going to be occurring. Okay, very good. Next question. Which finding indicates to the nurse that demiclocycline is effective for a patient with syndrome of inappropriate antidiuretic hormone? First of all, can anybody remind us? I said something about the demiclocycline. Can anybody remind us what the drugs do?
He said it blocks the effect of ADH on the renal tubes.
Okay. Very good. So now let's answer the question. Okay. Now let's answer the question. Which finding indicates to the nurse that demiclocycline is effective for SIDH? A, weight has increased. B, urine output has increased. C, peripheral edema is increased. And D, urine specific gravity is increased.
I think it's D.
D. Okay, someone has said D. Any other answer? But Mr. Nana, is it Mr. Nana answer? Please, why did you say D? The rationale to the D option.
Because you said it's going to block when they give the demiclocycline, it's going to block the activities of the ADH, right?
Okay.
Right. So given that, that means the kidney is going to function well. When the kidney functions well, you're going to excrete more urine. When you excrete more urine,
what occurs to the specific gravity?
Oh, okay, it decreases. Yeah,
Yes,
it decreases.
very good. So now you've gotten the answer.
It's B.
So it's B. Very good. Okay, it's B. Okay, so the answer is B. Okay. I like how you're able to connect it. Okay, and I like the rationale. Okay, so the demiclocycline blocks the action of antidiuretic hormone on the renal tubes, as I said earlier, and increases urine output. Okay, Even if you forget anything, you know, this is an NCLEX strategy in answering questions. Even if you forget about the microcycling, okay, we want to see the effectiveness of how the drug has worked on in SIDH. Okay, so meaning that weight has increased. In SIDH already there's weight gain. So that will not prove an effective management. Okay, in SIDH there's weight already. So that will not prove an effective management. Now let's go to specific gravity, the D. I'll come to the B and C. Let's go to the specific gravity, which is the D. Already in SIDH, you are holding water. So specific gravity is going to go up. So that one too is crossed out. Now we are left with B and C. B, there's urine output is increased. Very good, because in SIDH, the bouncer is there. The antidiuretic hormone is there. It is blocking the kidney or preventing the kidney from doing what? From releasing water. Okay, so we are giving the democlocycline to now increase urine output. So the B is a good option. Now the C, in the C, there's not going to be peripheral edema is increased. No. In SIDH, the patient just gets fluid overload with no peripheral edema. Okay, so that is what you should just know when it comes to SIDH. Okay, so now let's see the rationale. Democlocycline blocks the action of antidiuretic hormone on the renal tubules, and it increases urine output. An increase in weight or increased specific gravity indicate that SIDH is not corrected. Okay, peripheral edema does not occur with SIDH. A sudden weight gain without edema is a common clinical manifestation of this disorder. So these patients, they are increasing weight, but then there's no release or there's no hot edema as in peripheral edema in this condition. Okay, very good. Next question. Which patient statement indicates to the nurse that additional instruction is needed for a patient with chronic syndrome of inappropriate antidiuretic hormone? So we are going for what? A negative option. Okay, a negative option because additional instruction is needed. A, I should weigh myself daily and report sudden weight loss or weight gain. B, I need to shop for foods low in sodium and avoid adding salt to my food. C, I need to limit fluid intake to no more water than 1 quart of liquids a day. D, I should eat foods high in potassium because diuretics cause potassium loss. So what option are we going for?
B.
B, right?
Yes.
Why?
Yes.
Miss Manapana, please, why?
B. Okay. B because SIADH.
SIADH. We have dilutional hyponatremia.
Okay.
So we are encouraging the client to take oral salt.
Okay.
Or even if it's in emergency management, you give what? A hypertonic saline, which is 3%. But we wouldn't tell the client to eat low sodium, meaning they are going to worsen the hyponatremia.
Very
so I think, thank
Very
you.
good. That is rational. Okay. So patients with SIADH are at higher risk for hyponatremia, and a sodium supplement may be prescribed. Other patients supplements are corrected in the case that the patient has been occurred. So obviously the answer is B. Okay, the answer is B. Next question. Maybe I think this and then we can solve one last question on it, and then we move on to the next topic. Okay. Good. So is that the question? All of them are on. Oh, I showed the answer already. A 56-year-old patient is disoriented and reports a headache and muscle cramps, is hospitalized with SIADH. Which initial laboratory results should the nurse expect? Elevated hematocrit, decreased sodium, increased serum chloride, and low specific gravity. This one is simple.
B. Decrease serum sodium.
Is B.
Okay.
Is B.
Is B. The additional hyponatremia. Okay. This one is only the next explanation. Okay, good. Now we have another question here. Which problem should the nurse anticipate for patients admitted to the hospital with diabetes insipidus? Generalized edema, fluid volume overload, disturbed sleep pattern, and decreased gaseous exchange. What are you going for?
C.
What?
C.
I'll do it.
C. C. Okay. Why? Why C?
Because the patient will be urinating more frequently and also have to be visiting the washroom. And
Very
then
good.
they
At
will not
night.
be able to sleep.
Very
And
good. So the answer
also
is
and also you see you go back to the question and I'll tell you something.
okay.
You know, in diabetes insipidus, the client is losing fluid, so he's having what a dehydration. The client is going to have dehydration because he's losing the fluid. So generalized edema wouldn't be there. There will not be fluid overload.
Exactly.
Then they ask for the gas exchange. I cannot talk much, but the
out.
two are
Out.
all for the SIADH. Those A and B, they are for SIADH.
Exactly.
Thank you.
So you are really using the English strategies very, very well. The question answering strategies, eliminating the wrong ones, okay, and then focus on the right one. That is great. Okay, very good. Okay, so I think this will be our last question. Also, yeah. So the nurse would implement which nursing action when caring for a patient with syndrome of inappropriate antidiuretic hormone, SIADH? Initiate seizure precautions, elevate the patient to semi-paralysis position, increase fluid intake to at least 1,500 ml per 24 hours, and infuse hypotonic solution such as 0.45 saline. What are you going to do?
A, because of the cerebral edema.
A, because of the cerebral edema. Okay. All right. Okay. All right. So this one there, no, right. I will not even explain. Okay. You already understand. Okay. Good. Last question. I think this will be the last question. Which clinical manifestation of severe sodium level decline would the nurse assess in a patient who has cerebral edema associated with SIADH? Select all that apply. Coma, lethargy, confusion, headache, tachycardia, hypovolemic shock. What are you going for?
Select all that apply.
Yes. SATA. It's a SATA question.
Okay.
There could be coma. There could be coma.
So what A we pick A. So
yes.
A what?
B.
A B.
C.
And
D.
D.
A B C D. Okay.
A, B, C, and D.
F is not bad.
F is not bad.
It's not bad because hypovolemia is only seen in what diabetes insipidus. So this is a case of SIADH. So that one is the odd one out.
Okay.
No. Tachycardia, no.
A, B, C,
No.
and D.
Tachycardia, no.
Okay.
It's A, B, C, and D.
C and D. Okay. Let's look at the right answer. So we have A, B, C, D. Okay. It's as simple as that. You know, cerebral edema will cause coma, confusion, headache. Okay. Cerebral edema will cause coma, confusion, headache. Patients with more water, there's weight gain, they can have lethargy. Okay. But tachycardia moves with hypovolemia. So if you're not picking hypovolemia, just go tachycardia out.
Yes, okay.
It's as simple as that. Okay. Hypovolemia usually works with tachycardia. Anytime fluid volume level is down, there's tachycardia. So if you are not picking hypovolemia, then cross tachycardia out. So please, on your NCLEX, anytime you are picking hypotension, make sure that as part of your signs and symptoms, you are picking tachycardia as well. They move together. Okay.
Okay.
Very good.
Hypertension, hypovolemia.
Very good. Yes. So the A, B, C, and D. Okay. Good. So that is it for SIADH and DI. Please, I'm sure you are all enjoying the class.
Yes, please.
And we are following well.
Yes.
Okay. All right. That is good. So maybe we can do the thyroid gland. Okay. We can do the thyroid gland. We can do the thyroid gland. Okay. Very good. So which, if I may ask, which conditions do we have under the thyroid gland?
The thyroid gland. We have the
hyperthyroidism.
Hyper and hypothyroidism.
Hyper and hypothyroidism.
Very good. Hyperthyroidism and then hypothyroidism. Okay.
adrenal all the adrenal conditions, they're all under that one too.
Okay.
Are you talking of pituitary or you're talking of thyroid?
Thyroid.
No, it's not that one.
You know, when I understand what you just said, okay. You know, yes, I don't know his questions and this, but do you know something? When you have a disease of the pituitary gland, usually all your glands are affected.
Yes, because that's
tell me why? Exactly.
Because that's the master gland. It controls all.
Gland. Yes. Because the pituitary gland is the master gland. Okay, so when it's affected, it usually affects almost everything. Okay, so let's talk about hyperthyroidism. Okay. Now, for us to understand thyroidism very, very well, let's know what the thyroid gland do, okay, or what it does. So the thyroid gland usually produces what we call the thyroid hormone. And then this thyroid hormone helps with what? It helps basically with what? With metabolic rate, exactly. So thyroid gland secretes the thyroid hormone for metabolism, okay? The thyroid gland secretes the thyroid hormone for metabolism. It's as simple as that. The thyroid gland secretes the thyroid hormone for metabolism, okay? So in hyperthyroidism, the thyroid gland is excreting or secreting more than expected. So there's more of the thyroid hormone, okay? In thyroid gland, there is more of the thyroid hormone. It is just like that. The thyroid gland is secreting more of the thyroid hormone. So if we happen to have a condition whereby the thyroid gland is producing excessive of the thyroid hormone, we say there is what? There is what? There is hyperthyroidism. Okay. So some of the causes are here. We have family history or genetics. Okay. So if your parents have, or your father, your sisters, or they do have your siblings, okay, they do have what do you call it? Hyperthyroidism. You are likely to also get hyperthyroidism. We have autoimmune disorder, Graves' disease. Very good. So I'll talk about the Graves' disease because it confuses people. Okay, it really confuses people when it comes to Graves' disease, hyperthyroidism, thyroid storm. Okay, these three kind of confuse people. Okay, so let me talk about the Graves' disease here. In Graves' disease, it's a cause. In fact, Graves' disease is a cause of hyperthyroidism. This is what occurs in Graves' disease. In Graves' disease, there's an autoimmune disorder. Okay, there's an autoimmune disorder. Now, this autoimmune disorder is causing the release of what? Antibodies. Okay, this autoimmune disorder is causing the release of antibodies. So these antibodies is stimulating the thyroid gland to produce more thyroid hormone. So just know that Graves' disease is an autoimmune disorder whereby there's a release of antibodies, and this antibodies is stimulating the thyroid gland to produce thyroid hormones. So Graves' disease is a cause of what? Hyperthyroidism. Okay, it's a cause of hyperthyroidism. So let's take note. Another cause is the thyroid nodules or thyroid tumors. Of course, if we have cancer of the thyroid gland, there will be more production of what? Abnormal cells in the thyroid gland. And if there's more production of abnormal cells in the thyroid gland, this will contribute the thyroid gland to producing more thyroid hormone. Okay, so we have infections. Okay, and we have that thyroid tumors. You can also get infections like thyroiditis. Okay, thyroiditis can also contribute to the production of more thyroid hormones. Radiation exposure. Okay, if you have been exposed to radiations consistently, you can be at risk for getting what? At risk for getting hyperthyroidism. Okay, you can be at risk for getting hyperthyroidism. Medications like amiodarone and lithium. Okay, medications like amiodarone and lithium. All these medications can also contribute to getting what? To getting hyperthyroidism. All these medications can also contribute to getting hyperthyroidism. Okay, very good. Now symptoms. Good. So the symptoms is simple, okay? It's simple. Because there is production, or there is more production of the thyroid hormone. As I said earlier on, the thyroid hormone is for metabolism, okay? Yes. The thyroid hormone is for metabolism. So because there is increase of this hormone, there's going to be an increase in metabolism. So everything will go up, Okay, everything will go up. Madam Sylvia, please can you mute up? Please, Sylvia Kwashi, can you please mute up? Okay, good. So because there's increase in, because there's an increase in what do you call it? There's an increase in thyroid hormone. There's going to be an increase in what? In metabolism. So everything is going to go up. So option one, we have weight loss.
Okay.
Yes.
I will appreciate if you connect the T3 and 3, 4 in the explanation, please.
I'll go to the next slide. Okay, I'll go there. Okay, they are here. So I'll talk about it over here. Okay, very good. So the T3 and T4 are the thyroid hormones. Okay, but we will talk about it very, very much when we get to the next slide. Okay, very good. So we have weight loss. Why? There is increase in gastric motility. If you forget about everything, just know that everything is good. Yes, everything is going up. Okay, everything is going up. You eat, there's increase in peristalsis. So the stomach just digests the food and you are bringing them out. So that alone, you can get diarrhea and it can what? It can cause weight loss. There's increase in metabolism. You are sweating a lot. Okay, the usage of energy. In fact, even how you use your energy has been speeding. Okay, or has been accelerated. So you are losing your fluid through sweat, through perspirations. So you are going to lose weight. Okay, there's increased appetite. There's increased appetite. Everything is going up. So even your urge to eat will also go up. There's hyperthermia, increase in what? Temperature. There's hypertension. There's increase in what? Blood pressure. Because of what? Because of the increase in metabolism. Okay. There's exophthalmos, or what we call the bulging eyes. There's exophthalmos, or what we call the bulging eyes. Okay. There can be diarrhea. As I said earlier on, there's increase in what? Gastric motility. There's increase in what? Peristalsis. So you can get diarrhea. There's heat intolerance. Heat intolerance. This patient does not tolerate heat at all. They don't like heat, okay, at all. So there can be increase in what? Heat intolerance, okay, or there can be heat intolerance. So let's take note. There is sweating. As I said, you are using your energy. There's in fact, it's like, how do I say it? How the body processes its things, okay, has been accelerated, or everything has been increased. So you are going to get sweating. You are going to sweat a lot. There's going to be rapid heartbeat. There's going to be increased respiration. There can be palpitations, and there can be tremors. Okay. If you forget about everything, just know that in hyperthyroidism, everything goes up. Okay. In hyperthyroidism, everything goes up. Weight loss, increased appetite, hyperthermia, hypertension, exophthalmos, diarrhea, heat intolerance, sweating, rapid heartbeat, tachypnea, palpitations, tremor, and then mood swing. Okay, very good. Someone want to talk? Hey, who is right on my screen? Madam Ruth, you're right on my screen. Oh. Okay. So let's go to the next slide. Very good. Here I will talk a little bit here. Okay. When you get a question on your NCLEX, okay, and the question is a case study on either hyperthyroidism or hypothyroidism, usually either hyperthyroidism or hypothyroidism, please take note. Usually when it comes to what do you call it, the diagnostic investigation, they're going to bring the levels of the T3, the levels of the T4, and the levels of the TSH. It is very, very, very important. Okay, TSH, T4, and then T3. You should know them. Okay. In hyperthyroidism, there's a high T3, a high T4, and a low TSH. Okay, please take note. A high T4, a high T3, and then a low TSH. A high T3, a high T4, and then a low TSH. T3 and T4 are the what? Are the thyroid hormones. So obviously, there's excess production of the thyroid hormone. So what do you expect? They will go high or they will go up. So there's high T4, there is high T3. Okay, a high T3 and a high T4. These are the thyroid hormones, so they are going to go up. But then there's going to be a low TSH. The thyroid stimulating hormone is going to be low. Okay, the thyroid stimulating hormone is going to be low. The reason is that because the thyroid gland is producing more of the T3 and T4, the brain will not stimulate the thyroid stimulating hormone. Okay, it will not even go there. It will not even try to compensate at all because they are already high. Okay, so because they are already high, the brain will now try to lower the stimulating hormone, or it will bring it down so that there will be no production of more thyroid hormones. Okay, I'm sure you are getting it. Usually, before T3 and T4 will go up, there must be a stimulation hormone, and that one is the thyroid stimulating hormone. They must be stimulated by the brain to increase your hormone levels. But because in this condition, the thyroid hormones are already high, the brain will rather stop working. Okay, the brain will rather stop working on the TSH. So they are not going to produce more and even reduce it to compensate for the high thyroid hormones. That is why you are getting a low TSH and then a high T4 and a high T3. Okay, please, did the understanding go well?
Yes, please.
Yes. Very good. So the TSH is going to be low, the T3 and T4 is going to be high. Okay, the thyroid hormones, which are the T3 and T4, are already high. So the brain will not stimulate the hormone to even try to increase it. They are rather going to quiet it down, okay, so that the patient will not have more of the production of the T3 and T4. So that is something we can know as our thyroid function test to diagnose the hyperthyroidism. Okay, 2, we can do what we call the thyroid stimulating hormone receptor antibody test. Okay, so this one, we just take an antibody from the thyroid stimulating hormone and we give to the patient. We are observing whether the hormone levels will increase or it will decrease. So if the hormone levels increases, then you can conclude that there is hyperthyroidism. Okay, very good. 3, you are doing thyroid ultrasound. Okay, so you do an ultrasound of the thyroid gland to visualize how, or to observe or visualize what is going on in the thyroid gland. Okay. 4, we are giving a radioactive iodine uptake test, or that is what we are doing. So in this one, they will give you a radioactive iodine. Okay. Once they give the radioactive iodine, we are going to observe whether your hormone level will go up or your hormone level will come down. Okay. So we do this test and we give the radioactive iodine and we observe what will going to occur in your thyroid hormones. Okay. Very good. Now, pharmacology. Another NCLEX interest. Madam Mary, please can you mute up? Very good. Another NCLEX interest, especially with the methimazole and the pulpiturazole. Okay. The methimazole and the pulpiturazole. The methimazole and the pulpiturazole. Please, you have to know this. And I'm going to talk about the NCLEX areas that usually come for these 2 drugs. Okay. Methimazole and pulpiturazole. When you are giving this drug, it causes what you call agranulocytosis. Okay, so a patient came to your ward with hyperthyroidism, or you are an RN on duty, you took out the shift. A patient with hyperthyroidism being prescribed methimazole. Okay, and then you realize that all of a sudden, patient's temperature is going up. Okay, patient's temperature is just going up, or you draw blood levels to check the white blood cell count, and that one too is very, very high, indicative of what? Indicative of what? Infections. And you know that this medication we are giving is causing what we know the agranulocytosis. Okay, so usually when you are giving this drug, NCLEX will usually test you. You can just get a question like that. Okay, you can just get a question like that. A patient being prescribed methimazole, which of the following signs and symptoms, which of the following is going to occur? And you're going to see agranulocytosis. Okay, which of the following side effects should you anticipate? High temperature, high white blood cell count. Okay, high temperature, high white blood cell count. For clarification, can someone help us with the normal value for white blood cell count?
I think it's 5,000 to
5,000 to 11,000.
5,000 to
4,500 to 11,000. 4,500 to 11,000.
It's 4,000 to 11,000.
4,500 to 11,000.
You're good. So everybody will have their own value. Okay. It is normal for the books. In fact, fortunately for us these days, on your NCLEX, they bring the normal value on your case studies. Okay, you realize that they will bring the normal value for you to see. Okay, so it is very, very easy to identify whether it is high or low. Okay, on your NCLEX these days they bring it, but then please take note, in case studies, sorry, in standalone questions, they will not bring the normal value for you. You have to know your lab values. Okay, it is only in case studies that they will provide the normal value for you. Okay, so please let's take it as 5,000 to 11,000 as the normal white blood cell count. And anytime there's an infection, your white blood cell count will increase. Okay, anytime there's an infection, your white blood cell count is going to go beyond 11,000. So if a patient is on methimazole, or let's say 4.0 USL, and you are seeing these things, you should know that it's a side effect. Okay, so what do you have to do for this patient? You have to ensure that you are preventing infection as high as possible. You are preventing infection as high as possible. And the moment you initiate methimazole, you have to put measures into place to prevent infection. So what do? You do what we call your neutropenic precautions. Okay, your neutropenic precautions. So one, you are ensuring that there's no flower or there's no sun in the patient's room. Okay, you are ensuring that there's no sun or there's no flower in the patient's room. You are putting patients in a reverse isolation. Okay, you are putting patients in a reverse isolation. Reverse isolation means that you are just keeping patients in a private room and we are preventing all other infections from getting to the patient's room. Okay, that is reverse isolation. You have to restrict visitors as well. You restrict visitors so that the patient will not be exposed to infection. You prevent patients, or you teach patients to prevent overcrowded areas. Okay, you prevent overcrowded areas. All these goals the moment we start methimazole. Okay, prevent from going to overcrowded areas. Okay, so this is what we have to do. Some of the things that we have to do when it comes to methimazole. Okay, and property yourself. Second interest is on the maternal issues. Please take note, both methimazole and propartioacel can cross the placenta barrier and can harm the baby. Okay, please take note. Both of them can cross the placenta barrier and it can harm the baby, most of them. But do you know something? When you give the propartioacel at the first stage, it doesn't cause much harm. Okay, doesn't cause much harm. So in maternity, or if a mother is pregnant and the mother is taking these drugs, you give the propartioacel in the first trimester, and then you continue with the methimazole in the second and third trimester. Please, let's take it, or let's note this down. Okay.
Hello.
Yes.
Can I just chip in and ask a little question from this one, please?
Okay.
The reason why I'm asking this question is I saw a question. I'm aware that you are supposed to give first trimester PTU for first trimester, and then after that you give the methimazole. However, there was a question I got that they said the patient was 3 months pregnant, and I know the third month is first trimester. The answer was methimazole anyway. I chose methimazole, but I was still thinking, what if, because they didn't bring a PTU, and I was thinking, so what if they bring the two medication? What do I choose? Because I know
Okay.
first trimester is 1 to 3 months, and then the other one is 4 to 6, 4 to 6. So can you clarify on that for me? Thank you.
Okay. So when they bring the two options in your options, okay, say they bring propartioacel and the methimazole, all of these drugs in the options, and then they are asking what will you give in the first trimester. Please go for the PTU. Okay. Please go for the PTU. Okay. I don't know. The question that you had was did the question have both options in the same both options in the same question?
No, that was what I was saying. They didn't bring they just brought methimazole and the radioactive iodine and levetiraxim. So I was just
Okay.
thinking,
So you
what
go
if,
for the PTU in the
okay,
first trimester. If they bring both of them, just go for the PTU. Okay.
okay,
If they bring both of them, just go for the PTU. But if they don't bring it, you give the methimazole. You know, one thing is that the methimazole, as I was saying, both drugs can cross the placenta barrier. Both drugs. It is just that the PTU is more, or the methimazole is a bit harmful in the first trimester. That is why you consider the PTU over the methimazole. In some instances, they give the methimazole. It is just that it can have significant effect on the baby. That is why usually we give the PTU. And then the second and third trimester, we give the methimazole. Okay. So if on your options, you don't see the two of them, okay, and you can go for the methimazole. But if you see the two of them, let's just go for the PTU. Okay. All right. So that is it. So these are the things that you should know when it comes to NCLEX interest with these drugs, agranulocytosis and what, and then how they are administered in maternity or in pregnant women. Okay, how they are administered in pregnant women is very, very concerned. Two, we are giving beta blockers. Okay, we are giving beta blockers like propranolol. These patients already have high temperature, high hot. This patient have high temperature, it have high heart rate. So we can give propranolol. Propranolol can reduce their BP and can also reduce what? Their heart rate. That is why we are giving propranolol. Okay. Then 4, we are giving antipyretics. There is hyperthermia. Okay. There is hyperthermia. There is hyperthermia. So if there's hyperthermia, then of course, what do? We have to give antipyretics to reduce their temperature. Okay. We have to give antibiotics to reduce that temperature. We can give IV fluids. Okay, we can give IV fluids. We can give IV fluids because patient is having diarrhea. There's increase in gastric motility, right? So patient is having diarrhea, so you must prevent dehydration. So you can give IV fluids, okay, as a way to help the situation. Okay, very good. Very good. Now, if I may ask, before we even talk about the next intervention, if I may ask, what arterial blood gas interpretation, okay, what abnormal arterial blood gas interpretation are we going to see or are we going to get in hyperthyroidism? Hello.
Hypocalcemia.
No, that one is electrolyte imbalances. I'm talking about
respiratory alkalosis.
Respiratory alkalosis.
Metabolic acidosis.
Metabolic acidosis.
Metabolic
It's
acidosis.
metabolic.
Very good. Why? Someone should, yes, Mr. Santi. Why?
Hello, boss Aki.
Yes.
Like like because there's hyperthyroidism, like everything will be going right. So the patient will try to hyperventilate. So as the patient hyperventilate, I think more acid will be coming out. More this thing, carbon dioxide will be coming out. So it will let it for this. That's what I.
Okay. That one is okay. Very good. It's fine.
Let me also come in there.
Okay.
You know, we said this this condition, this everything is the excess. It's like the body is working extra. So this thing is, first of all, you have to know that it's metabolic because this thing itself is a metabolic kind of thing. Then secondly, you know, we said there will be what diarrhea. And diarrhea will lead to the acidosis.
Very good. So just simply, okay, there is diarrhea. Patient is losing all their bicarbonates through the stools, okay, through the diarrhea. So if you are losing all your sodium bicarbonates through the stools, what will be left is acid. So you are going to get metabolic acidosis, okay. Very good. So let's not forget, there's going to be metabolic acidosis as well. Very good. Nursing interventions, okay, for this patient. You monitor patients with daily, okay, because there is what? There is diarrhea, there can be weight loss. So these patients, you have to monitor their weight daily with the same weighing scale and what? With the same what? With the same clothing. So you have to monitor the patient's weight daily. 2, you observe for dehydration and electrolyte imbalances. Okay. I just finished speaking about what? Just finished speaking about diarrhea. So because there can be diarrhea, there can be dehydration. So you observe for dehydration and electrolyte imbalances. Okay, electrolyte imbalances. 3, nurse patient in a cool environment. Okay, the iron must nurse the patient in a cool environment because there is heat intolerance. Okay, there is heat intolerance, so you must nurse the patient in a cool environment. Observe patient BP readings. Okay, so there is what do you call it? There is BP, high BPs, hypertensions. Okay, everything is going up, so there's high BP readings. So what you have to expect, there's going to be hot. You have to observe the patient BP. So this patient, I'm asking this question: can we give dopamine to this patient?
No.
Because dopamine is falls under which class of drugs?
I know truth.
And then it does what?
It increases BP.
Okay, it's a vasopressor. Okay, yes, dopamine. Exactly, dopamine is a vasopressor. Okay, it controls blood vessels. So on your end, you see a question: a patient diagnosed with hyperthyroid. What do you call it? Patient diagnosed with hyperthyroidism. Okay, which of the following drugs should you clarify as an iron? Then you see dopamine, you see adrenaline. Then you should know that these drugs should be clarified. Okay, very good. 5, dietary changes. You should give them low iodine diet.
Please come again. Sir,
Okay,
please come again.
Okay, I was saying that, dopamine and then these drugs like dopamine, adrenalines, okay, dobutamine, these drugs are vasopressors, okay, and they are inotropes. They cause vasoconstrictions and can increase your blood pressure. And then, in hyperthyroidism, everything is going up. There's increased metabolism, there's increased heart rate, there's increased blood pressure. So you're going to get high BP. So it will be wrong to it will be wrong to concurrently take dobutamine or dopamine in this condition. Okay. So I was saying that if you see a question on your NCLEX, a patient admitted onto the ward with hyperthyroidism, which of the following drug would you clarify? A, dopamine. Okay. A, dopamine. B, metoprolol. Okay. Metoprolol. C, IV paracetamol. Then you should know that you are going to clarify what? Dopamine, because dopamine is a vasopressor. It is going to increase your BP. So usually you don't have to give in this situation. Okay. Very good. 5.
Thank you.
5. You're welcome. 5. You have to give them a low iodine diet. A low iodine diet. Do you know why? Do you know that before thyroid hormones will be produced, the thyroid gland needs iodine to synthesize thyroid hormones. Okay, good. Let's take it like that. This is a pathophysiology for goiter. I'm trying to show you why. I'm trying to explain why we have goiter as a complication, or we can even see goiter a lot. Okay, in goiter we say goiter occurs when there is what? There is iodine deficiency. The thyroid gland needs iodine to synthesize thyroid hormone, or the thyroid gland needs iodine to produce what? Thyroid hormones. So in goiter, the iodine is low. The patient has low iodine, so the thyroid gland is not producing enough of the thyroid hormones. So what do you expect? The thyroid gland will overreact, and this overreaction of the thyroid gland will cause that swelling, leading to the goiter. Okay, patient does not have iodine. Meanwhile, the thyroid gland needs the iodine to produce the thyroid hormone. So because the patient does not have the iodine, then the body will speak to itself, Charlie, let me overreact to produce the thyroid hormone. So because of the overreaction of the thyroid gland, then we get goiter. Okay, very good. So in hyperthyroidism, patients already have more of the thyroid hormones. Okay, in hyperthyroidism, patients already have more of the thyroid hormones. So we don't need any iodine again to increase more production of thyroid hormones. So we have to give them a low iodine diet. Okay, very good. 6, we are giving them a high carbohydrate diet because patient is having diarrhea. There's increased gastric motility, so their food should be high in carbohydrate. Okay, but we are giving them a low fiber diet. Of course, we can't give a high fiber diet to a patient who is running or patient who is having consistent diarrhea. You have to give them a low fiber diet. You have to engage them to manage their stress, engage them in diversional therapies to help them control their stress. 8, you administer sodium bicarbonate. Okay, you have to administer sodium bicarbonate because of the metabolic acidosis. You are bringing all the base out through diarrhea, so you must administer sodium bicarbonate. Then 9, you are ensuring regular exercises. Okay, you are ensuring regular exercises for this patient. Good. Very good. Thyroidectomy. This is the surgical intervention that you can do. Okay. Now you are giving your proprietary USRN, you are giving your methimazole. Still, patient is still producing more thyroid hormone. So what do? You can do a surgery to take away the thyroid gland. Okay, you can do a surgery to take away the thyroid, and that is a thyroidectomy. So thyroidectomy is the surgery you do to remove the thyroid gland. Okay, to control hyperthyroidism. Again, I'm repeating myself. I said earlier on that when it comes to questions on your NCLEX regarding what you call surgical interventions or surgeries, usually you get questions on post-op. The pre-op is just a few of them. Okay, so please let's take note. Okay, let's take note. So in hyperthyroidism or in thyroidectomy, patient has been scheduled for thyroidectomy. The pre-op, you are giving them the Lugol solution. The Lugol solution. This solution is given to reduce the vascularity of the thyroid gland or to control bleeding. Okay, it is given to reduce the vascularity of the thyroid gland or to control bleeding. Please let's know this, that the thyroid gland it consists of plenty blood vessels. Okay, plenty blood vessels and plenty arteries. So we have more veins and arteries in the thyroid gland. Okay, there's more arteries and then veins. Thyroid gland. So these patients, they bleed a lot when you tamper the thyroid gland. So to prevent the excessive bleeding after the procedure, we give them this solution called the Lugol solution. Okay, you have to give them this Lugol solution. This Lugol solution will decrease the vascularity or to help control the bleeding after the surgery has been done. Okay. So you can get the question on your NCLEX. A patient has been scheduled for thyroidectomy or thyroidectomy. What is the indication as to why we are giving Lugol's solution? Then you see in the answer to control bleeding, you pick it, or you see to decrease the vascularity of the thyroid gland. Then you know that you are on the right track. Okay, so once we give this solution after the surgery, the bleeding will be controlled. Okay, that is why we are giving this solution prior to the procedure. Okay, very good. Now, when you finish the procedure and you come to the ward on your NCLEX, so you see I've indicated the NCLEX tip. Usually, NCLEX tests us on 4 basic things. Okay, 4 basic things after thyroidectomy. 1, hypocalcemia. 2, bleeding. 3, infections. And 4, stridor or stridor. Okay, 1, hypocalcemia. 2, bleeding. 3, infections. And 4, stridor. So a patient underwent thyroidectomy. Okay, usually after the procedure has been done, they experience what we call hypocalcemia. Okay, the reason why they experience the hypocalcemia, I'm sure this we all know, is because at the back of the thyroid gland is the parathyroid gland. Please let's take note too. At the back of the thyroid gland is the parathyroid gland. Okay, we have the parathyroid gland just at the back of the thyroid gland. Let me see if I can show you a picture of it. Okay, parathyroid gland. Okay. Please, can we see? Can you see my screen? Hello. Hello.
Yes.
Yes, please.
Very good. So we see. Have you seen
Please, we can
these 4?
see.
Have you seen these 4 yellowish organs here?
Yes,
These
we
are
can see.
these are the parathyroid glands. Okay, they are just at the back of the thyroid gland. So in thyroidectomy, when you take off the thyroid gland, you can take off this parathyroid gland as well. Okay, accidentally you can remove this parathyroid gland as well, and this is why we get hypocalcemia, because the parathyroid gland is there to regulate calcium. It produces calcium and ensure that it also regulates calcium. So in a situation whereby these glands has been taken off, after thyroidectomy, you are going to get hypocalcemia. Okay, very good. Please, I'm sure we are okay. Very good. So that is why you are getting hypocalcemia. Okay. And then on your NCLEX, the hypocalcemia is really observed by what? The Trausian sign and then the Chivostek sign. Okay. The Trausian sign and the Chivostek sign. The Trausian sign and then the Chivostek sign. Let me show you a picture of it. Trausian sign and then Chivostek sign. Okay. Usually, this is what we see. We have to note the picture. Sometimes NCLEX can bring a picture for us to identify. Okay. So let's see the picture very well. Okay. Let's see the picture very well. So in Trausian sign, you apply a BP cuff or a BP cuff to the patient's arm, okay? And then you inflate it above the systolic pressure for like 3 to 4 minutes, okay? You inflate it above the systolic pressure for like 3 to 4 minutes. When you do that, you realize that the hand is trying to flap, okay? The hand is trying to shake. Then you see there is what? You see how the hand has bent here. You see there is Trausian sign, okay? There is Trausian sign. And then in Chivostek sign, you try to hit the patient's chin. Okay, when you hit the patient's chin, you realize that there is what? A vibration movement over that area. Then you see there is what? Chivostek sign. Okay, there is Chivostek sign. So that is the difference. Let's take note. NCLEX can bring an image for us to identify. Okay, very good. That is how we identify hypocalcemia. With regards to bleeding, you can bleed. As I said earlier on, that the thyroid gland is very, very vascular. It has a lot of blood vessels, so you can bleed. After the procedure has been done, you observe the bleeding by a patient verbalizing that there is what frequent swallowing. Okay, if the patient tells you that, Nurse Mary or RN Mary, I have frequent swallowing. After the procedure, I'm having frequent swallowing. Then it should start signaling you of what, or it should give you a gist that patient is having what bleeding. So let's take note. Bleeding is elicited with frequent swallowing after thyroidectomy. Okay, and infections, of course, patient has gone to theater and is back from theater. There's a surgical incision, so there can be infections. And the infections, we are seeing high temperature, high white blood cell count. Okay. Then the last one that NCLEX usually tests us on is the stridor or the stridor. Okay, the stridor or the stridor. Please, when you see the stridor, this one is an airway emergency. It's an airway emergency. And what this means is that there is an airway occlusion as a result of bleeding, okay, as a result of swelling. You know, this patient has undergone surgery. Okay, so there can be inflammations on the thyroid gland. This can cause what? Can cause swelling, and it can cause a closure of the airway. And also, bleeding can also cause the airway to be blocked. So we are getting the stridor or the stridor. Okay, so let's not forget. And then, you know, among these ones, usually the stridor is a priority among the hypocalcemia, the frequent swallowing, the infection, the stridor. Usually, the stridor is the priority here because of the airway closure. Okay, because of the airway closure. Very good. Other things that we can do after the procedure is that we ensure the presence of tracheostomy set at the patient bedside. This one is placed there because when there is the airway closure in the stridor and the patient is not breathing, you create the opening in front of what? The trachea or in front of the neck so the patient will breathe through there. Okay, that is why we must keep the tracheostomy set at the bedside. You suction and provide oxygen as necessary. Okay, we suction and provide oxygen as necessary. These patients can do, okay, because they can be bleeding and then all those stuff. So you can suction to reduce it, and you can give oxygen because of the stridor. Patient in a semi-fowler's position and support the head with pillows. I forgot the bleeding. The bleeding. You see the bleeding is with either frequent swallowing or a pool of blood under the patient's neck or under the patient's head. Okay, so as the patient is lying down, you supported the head with pillows. When you check the patient's head, at the back of the head or under the patient's head, you realize there's a pool of blood over there. This can indicate that there's bleeding. okay? And then you must arrest hemorrhage as fast as possible. So you put patient in semi-fallout position, and then you support the head with pillows. 8, you have to expect hoarseness for like 3 to 4 days after the surgery due to edema. Okay, I said that, this patient, what do they experience? They get inflammation after the surgical procedure. So you can expect what? Hoarseness 3 to 4 days after the surgery due to what? Edema. Okay, very good. Now we do what we call the radioactive iodine therapy. Okay, we can expose them to radiations, and radiations will kill the cells, and then it will decrease the amount of hormone being produced. Okay, we expose them to radiations, and the radiations will kill the amount of cells that it is there to prevent the overproduction of what? Of the thyroid hormone. So in the radiation therapy, once we begin it, these are some of the teachings that we give to the patient. Patient's teaching. You can get this question on your NCLEX. Okay. Patient came with hyperthyroidism, and then we started what? Radioactive iodine. Which of the following should you select as part of the statement that patient's teaching has been what? Has been understood? So 1, you avoid sharing utensils. Okay. You avoid sharing utensils. The patient shouldn't share their urine utensils because of the radiations. They should wash their clothes separately. Okay, they should wash their clothes separately. They should sleep in a separate room. They should sleep in a separate room. They use a separate bathroom, and then they flush 3 times after the use. Okay, you have to flush 3 times after the use, and then they have to avoid pregnancy 4 to 6 months following the administration of this iodine. Okay, so please let's take note. Let's take note of these things. We can get on our NCLEX. You avoid sharing utensils. You wash clothes separately. You sleep in a separate room. You separate bath house, and then you flush 3 times after use. Okay, you avoid pregnancy 4 to 6 months following administration. Okay.
Hello.
Yes.
Please, the separate bathroom that you are saying, is it toilet or bathroom? Because I saw one question, and it's like there was a bathroom and there was toilet, and I think I picked the bathroom. They say it's not bathroom, it's toilet.
Toilet, yeah. So you can see as part of my option, I said flush 3 times. Okay, you can't flush the room. Okay. Okay. So usually is the toilet seat. Okay, there's toilet seat. So once you use it, you flush 3 times.
Yeah, hello.
Yes.
So I wanted to ask, so would the nurse wear a radioactive
Yeah,
safe
you wear a
clothing?
lead apron. Okay, you wear a lead apron. So the nurse must wear a lead apron, and then also they wear what you call the dosimeter badge. Okay, the dosimeter badge. The dosimeter badge is used to measure the amount of radiations being emitted from the patient. Okay, so the nurse must wear a lead apron, and the nurse must wear a dosimeter badge. And also, when you are caring for this patient as an RN, you must cluster your care. Okay, when you go there, you do everything, and then you leave the patient's room. You don't have to consistently, you check BP. Like, let's say you are checking vital signs, you check temperature, and you forgot, and you come back, then you go again and check BP, then you come back and check respirations. Okay, you have to cluster everything and do all of them at once to prevent the amount of radiations you have been exposed to. Okay, so let's take note of that one too as well. All right.
This, please, hello.
And then you will change the nurses too, the shift of the nurses. So it shouldn't be a dedicated nurse in that room, so that will limit the exposure.
Exactly. Yeah, exactly.
This reminds me, I had one question then. It was like, I can't remember the question, but the question was like about a client who is on radioactive therapy. Which of them, the distance is priority? Is it the nurse wearing the apron, the nurse doing the cluster of minimizing a number of like contacts with the client? And I think the number of contacts with the client takes priority as compared to that of the wearing of the apron.
Okay.
So that's a prioritization that we should always pay attention to.
Yes, so let's take note. Okay, it's very, very important. Okay. All right.
And I think also we shouldn't allow a pregnant RN to attend to them.
Exactly. Yes, exactly.
Hello.
Yes.
Please, how long should the nurse be in the room?
Okay, usually
not more than 30 minutes.
Exactly. not about 30 minutes. They don't spend more time in the room, okay? They don't spend more time in the room. Okay, very good. Yes, RNPs. I can see your hand up.
Yeah, please. The sister who said something about the priority for the clustering of the care and wearing the apron. Please, can she come again? I didn't get what the answer was.
I said the question was like a client who's on a radioactive what is it, a therapy or something like that. And I think the answers was like which one is the best or takes priority. So, and there was wearing of the lead apron, and there was also what you reduce your exposure to the client, like number of, as we are saying, perform class of activities. So if you are not doing the class of activity, and like she said, go and check BP and later go back and check temperature, you see that you are like you are having more frequent contact with the client as compared to when you plan and go and carry out all your activities at once. You see that your number of times you are exposed to the client is less. So that one you will not get, you are not exposed to the race as compared to somebody. You, I don't know how to. So that one was
Yeah,
taken priority comparing to that of the wearing of the lead apron. If you wear lead apron and you are sitting in the room 24/7, which one would expose you the next to get the impact of the radiations? That's what they want to find out. I don't know
Oh,
whether
okay. So the clustering of care is
it's
priority more than
yes, priority.
the
Because
oh,
I would
okay.
say wore the apron. Is it the whole body that wore the apron? It's not the whole body. So you sit in the room for 24 hours because you've worn apron. Then you are likely to expose yourself to danger.
Yeah.
Thank you.
Yes. Okay.
Please,
All right.
I want to clarify something. In the nursing manual, you said, I don't know, it's not the radiation therapy side, but the nursing care for it. You said they should do exercise. So I was asking what in relation with the exercise
Oh,
to
it is
some
just a normal. It's just a normal.
because I was looking at already the body is in the active state and the metabolism is already high, everything is high. Client have lost weight, so what is there any need for exercise again?
The exercise is not a vigorous one. Okay, just you can't keep patient two at one side simply because the patient is having, let's say, hypertension and all those. It's not a vigorous exercise. You just engage them in exercise to release stress. Okay, and also even sometimes it helps to reduce depression. Okay, that is why you engage them in a passive exercise, not an active exercise. Okay, just a passive one. Okay, all right, good. So that is it. So we are talking about the complications now. I think this is the last slide. It's already 7. So this will be the last slide, and then we can end the class. Okay. All right. So the complications of this condition, we get a thyroid storm. Let me talk about the thyroid storm. The thyroid storm it's a severe complication of the thyroid. Hyperthyroidism. Okay. It's a severe complication of the hyperthyroidism. Okay. Let's not forget. In thyroid storm, this is not a different condition. It is simply a situation whereby there is an exaggeration of the hyperthyroidism due to certain factors. Okay, due to certain factors. So patient probably is not a patient with hyperthyroidism. Okay, patient have hyperthyroidism, and the patient is not responding or adhering to the treatment regimen. The patient is not taking the methimazole and the propranolol. The patient again is not adhering to treatment regimen, is engaged in a lot of stress, a lot of all these things can cause the patient to get thyroid storm. The patient is smoking. Okay, usually we have the 4S when it comes to crisis, and I think this one is like it runs through major causes of crisis. Okay, we have sepsis, infections. If a person have a condition and they have infection, they can get to the crisis of the condition. Okay, so we have sepsis, we have smoking. Okay, and then we have stress. This okay, or the Christ condition, an exaggerated form of the thyroid storm. Now, in this thyroid storm, or the other name is what they call the thyroid toxicosis. Please, can we mute up, Madam Gloria? The other name for this condition is what they call the thyroid toxicosis. Okay, it's the same thing. Thyroid toxicosis is the same thing. And in this condition, yes.
Please come again with the 4S.
Okay, so we have sun exposure, we have smoking, we have stress, and then we have sepsis. Okay, sun exposure, smoking, stress, and sepsis. Okay.
Okay. Thank you.
You're welcome. So when this occur, or when these instances in the thyroid
Can
storm,
you repeat it for me? My children made my couldn't hear. Can you repeat the S?
smoking, sepsis, sun exposure, stress. Okay, smoking, sepsis, sun exposure, stress. Okay, very good. All right. So when these things occur and the patient gets thyroid storm, in thyroid storm or thyroid toxicosis, is simply an extreme form. Okay, it is simply an extreme form of hyperthyroidism. So the patient will present with the same signs and symptoms of hyperthyroidism, but in this one, in an exaggerated form. So if the patient with hyperthyroidism was getting BP of like, let's say 150/90, or let's say 150/100, in thyroid storm, it is going to go to like 200/120. It is just a severe form of it. Okay. In hyperthyroidism, patient is having diarrhea. Okay. Patient is having diarrhea. Because patient is having diarrhea, in thyroid storm, it's going to be a severe diarrhea. You get it? It's the same sign as symptoms, but here in a severe form. Then we say that the patient is having what? It's having thyroid storm. Okay. It's having thyroid storm. Okay, good. So we can get heart failure. Of course, there is severe tachycardia. It can even lead to atrial fibrillations. Okay, it can even lead to atrial fibrillations. That can lead to what? Heart failure. And we can also get stroke. Okay, we can also get CVA. Even atrial fibrillation in itself can lead to CVA. There's hypertension, consistent hypertension. If you are getting hypertension, there can be hemorrhagic stroke, whereby the blood vessels will be ruptured. Okay, so you can get stroke. And if stroke sets in, there will be cognitive impairment. Okay, so these are the complications of what? Of hyperthyroidism. Okay, our time is almost up, so we will end it here. Please, if you have any question, you can ask. Okay, if you have any question, you can ask concerning hyperthyroidism.
So please, will you put the audio, the recordings there immediately for us? Or when are we getting it?
Oh, of course, yes.
Please, can you repeat the SS for me?
Dia will do that. Oh, the SS, it is trending.
You help me because
as soon as you repeat the SS, someone should repeat it for her.
It says smoking, sepsis, sun exposure, and then stress.
Okay.
Sepsis, smoking, sun exposure, then stress.
Okay, all right, that's fine. Yeah, I can see what I'm saying.
Do they cause thyroid storm? The sun exposure,
yes, they can call it
thyroid storm.
Yes.
Okay.
Yes. So
does it mean the patient is not exposed to sun, or is like heat? Is it the heat exhaustion?
Okay, consistent exposure or frequent exposure to sun can lead to that. Okay, even those things can even increase stress. Okay, when you are constantly under the sun, it can increase stress, and you can get the thyroid storm. Okay.
So they shouldn't work under the sun. Like us in the continuous exposure.
Exactly.
So if the person sells in Mokola,
they use a sunscreen.
Exactly, sunscreen. Very good. They use a sunscreen. It's a cream. Okay, when they apply it on your skin, and it can now work in there.
Then a big hat. Okay.
And then a big hat.
Exactly. Okay, you are there. Okay, you are there. All right. Okay. But do you know? I'm sure you know that in US. Let me chip this in before you come. Okay. I'm sure you know that in US, their time frame for sun exposure is 8 to 10 a.m. If like these conditions that, like, let me say conditions like systemic lupus erythematosus, okay, these ones, they don't really like sun exposure as well. They should be exposed to sun only from 10 a.m. to 4 from what do you call it, 8 a.m. to 10 a.m. Between 10 a.m. to 4 p.m., don't expose patient to sun. Okay, don't expose patient to sun. Okay, so to prevent crisis like thyroid storm, you don't have to expose the patient to sun between 10 a.m. to 4 p.m. Okay, all right, very good. Yes, someone want to talk, Madam Jane.
Yes, please.
Hello.
Taking you back small. When it comes to you, effects, is it applicable to the two? Hello? Hello?
Yes. Please, can you repeat the question?
Yes, I'm saying that.
Oh, is it the network? I'm not hearing you too. I'm not hearing anything. I don't know if the network. Please, can you hear me? Yes, Madam Jane, please can you repeat it? Okay.
Hello. Yes, I'm saying that the two side effects, the high body temperature and then the agranulocytosis, does it apply to both methimazole and then the PTU?
Yes, usually, yeah, it's both of them. Okay, it's both of them. Yes, both of them. Okay. All right. Please, any other question? Any other question? Please, any other question? Please. Oh, we are okay. We are okay.
Yes.
Okay. All right. I'm sure you all enjoyed the class.
Yes, we did.
Very well, sir.
Okay. All right.
We
That is
really
fine.
enjoyed it. Thank you.
A very interesting class.
Okay.
Hello.
Okay. Yes.
I've left a question on the page. Please, can we check it because it's very, very confusing. It's about
Very well.
No, not a
Which question?
I've left it on the masterclass page. It's about what did we talk about? SIADH and then the DI. The question was very
Okay.
because the question looked like the patient has DI, and I chose vasopressin. However, the answer was wrong. So it's really if somebody can go through it and then we talk about it. Thank you.
Please, I want to just find out something. When do you think that one have to use what is it? Let's say you have to the question bank. When do you start using it?
Oh, I'll come to that. Okay, I'll come to that.
Yeah,
Okay.
I'm 2 months in the distance system, but it's like some of my colleagues, when I said, they say I've even kept low, I can start using. I don't understand. I don't know whether do you have to finish all my content before I enter into. I'll start using that
No,
one.
we recommend that, as Yakut said, we recommend that you start using the Q bank 2 months before your test. I mean, when you have 2 months to your test, you start using the Q bank. Okay.
Okay, but you don't
Yes,
now.
2 to 3 months, 2 to 3 months before the test, you start.
Okay.
Yes. Okay. So the question you said a patient was admitted for intracranial hemorrhage 4 days ago. Okay. Modern laboratory results demonstrate a low sodium, so there is hyponatremia, osmolality of low serum sodium, a low serum osmolality of a high urine osmolality, and high urine sodium of vital signs are stable. Urine output is high. Averaging greater than 100 cc per hour. Which nurse intervention should the nurse include when planning care for a patient with cerebral salt wasting? Cerebral salt wasting syndrome. Oh, okay. So this is a different condition altogether. Okay. This is a different condition altogether. We have the cerebral salt wasting syndrome. Maybe we'll talk about that in our next class. Okay. Maybe a brief one on it before we begin the next class so that we don't confuse ourselves. But where did you get a question from?
From Lippincott.
Wow. Okay. All right. We will talk about it, okay, maybe in a brief manner next week.
Okay, that's fine.
Yes.
Do you know the answer
Okay.
they chose was sodium and fluid replacement?
Okay. You know, they are even saying salt wasting, right? So even that one should give you a clue. Or am I lying?
But then I was thinking, this is DI. Yeah, DI, and DI there is hypernatremia. So what does, I don't know. It's a whole lot. All right. Thank you.
You're welcome. Okay. You're welcome. So on next week Saturday, we will try and talk about this.
I think at the end the question stated the condition of the client.
Exactly.
So I'm sure
Exactly.
yes, you shouldn't have even finalized by giving DM because the condition is already there.
Exactly. Okay, exactly. All right. So that is it. Okay. We will end here for today. Okay, and then meet on Saturday. We will end here for today and then meet on Saturday. Okay, since you don't have any question, any additions to make, then we are going to end the class. Okay. All right, good. So thanks for joining today. We continue to